namna hii, namna hii, namna hii. Muka from outside, from Germany, from Uganda. It's always a pleasure to have you here. So we are also expecting other colleagues who are coming today. But due to this pandemic situation, so all of us, we know that it's not really easy to have all people that we're expecting. But so far so good, at least we have some of them who are going just to support us during this 9th Forensic Summer School. So it has been a habit to organize this, but last year we couldn't be able just to organize due to the pandemic again. But this year we tried again in June. It couldn't happen. And now we are here beside the new restrictions that you know. So again, I want just to welcome you, all of you, participants and their colleagues, and especially those who are supporting this organization of summer school. Our key stakeholders, the Rwanda Forensic Lab, RIB, National Police College, University of Rwanda, of course, and other partners that I mentioned here. So I want just before we start to show you some of the colleagues who are here. I mentioned Oliver, who has been the engine of this, just on the German side, in collaboration with our local organizing team. Ori, welcome. Yes. And then we have Fabian. Fabian is also a colleague who's really involved in the forensic science and has been in Rwanda. This is, I think, his second time coming here just to support us for this forensic summer school. So they will be just selecting and also having some lectures. So, and I also have a pleasure to introduce to you a friend and also a colleague. He used to be our Dean of School of Medicine, Samia Zebak, Professor Patrick Chamangwa from Kampala International University. Welcome, Patrick. He's Deputy Vice Chancellor at Kampala International University. So he's here with some colleagues who will be also participating in this summer school. Welcome, all of you. And I also want to show you my local team here who will be supporting, who has been really interacting with some of you for preparation of this summer school. Those who are going to present their abstracts. So the team here is led by Dr. Herbert Mushumba and Kalisa Joseph and other colleagues behind there who have been interacting with some of you. So again, today is only a full day session for lectures, as you have seen in the program shared with you. Due to this problem of not just getting a lot of people in the same room here, so we also, this year, we also introduced a live streaming program. So those who are not able just to attend these sessions, we could just follow the sessions through the live stream. And as I was mentioning, today we have, and tomorrow we have lectures, sessions, with different fields of forensic summer school, and with different international partner experts and local partners who are going just to take you through this session. And after these 2 days, we have other 2 days workshop, hands-on for the lab, for also other sessions like a trauma with psychologists and expert team will be here. So the program will be communicated during the sessions. So once again, I want just to welcome you, to wish you good participation, and feel free to interact. We want just this to be always interactive session, as we have been doing this before. And tomorrow, just to conclude, tomorrow will be the official opening ceremony, where we expect to have some officials just attending the event. Again, thank you very much for your participation, and enjoy your day.
Thank you very much, Professor Leo. I think now you feel comfortable. So we're going straight to the presentations, and the first presentation will be from Dr. Herbert Mushumba, and who'll be speaking about body stuffing and body packing, forensic control of human excrements in police custody in Hamburg, Germany. So welcome, Dr. Herbert. You can share the link with your colleagues who have not been able to join, to follow live on YouTube. Thank you. Herbert, you're welcome.
Thank you so much, Joseph, for the introduction. And straight to the point, with the first presentation of the day and of this year's summer school, I want to talk about a very important topic that some of you might have heard about, or if it's your first time, I hope you will learn something from the presentation. And feel free to ask any questions, make notes, and I will be happy to take the questions at the end of the presentation. So we'll begin with, this presentation is about our recently published paper on this topic. It concerns the cases, some of the work that we do or that is done at the Institute of Legal Medicine, or that we do as forensic practitioners. And as they're working on the PowerPoint presentation, on the presentation now, so we've had this kind of work for very many years, which is not common in our country, but we hope that it will start as well as the years progress. But we do have some cases of body stuffers and body packers. Of course, when I talk about the definitions, then you will understand what that is. So next. Next. So this is just, like I said, it's just a brief presentation, PowerPoint presentation, but if you want to read the full article, there is a link to the article, and then you can read it. You can read it in your free time. I'm also happy to share the presentations after. So to begin with the definitions, we have to start with and understand that concealment of illicit drugs, like for example, cocaine, heroin, hashish, for example, depending on what is available. Sorry? Yeah, depending on what drugs are available in the country, in each country, people tend to always devise ways to, people always tend to devise ways to conceal these drugs from law enforcement agents, the police, investigation authorities. And so sometimes the most common thing is hiding it in the human body. And concealment in the human body can be multifactorial. There are some who decide to hide that in the body orifices, like it's usually concealed for transportation over longer distances. And most of the times are in custody, in a police room that is closed, that is, has no, my slides are clear, I think so. So if you look at the males accounted for 98.6%. Of course, this is understandable. Most of the staffers are people who are on the street, and of course, sometimes it needs people who are very agile once they are confronted by the police. So it's not a surprise when the males account for the biggest percentage of it. When you look at the age in years, of course, it's tended, Mali, then you had some cases from Syria, from Germany, from Gambia, Ivory Coast, Nigeria, Libya, Morocco, Senegal, Algeria, Portugal, Turkey, Iraq, Iran, Togo, and Russia. And in 9 cases, the country of origin was not indicated. So we also tried to find out when or during which time of the year this was prevalent, and the majority of the cases were from July, September, October, November, and December. But of course, the difference wasn't that big. But of course, we tried to speculate what the explanations might be, as I will talk about in my next slides. So in all the positive drug toilets, only 13 drug toilets were positive for or contain drug containers, or suspected drug containers, because I'm using suspected because even when we find the packages or the containers which are properly wrapped, like I said, in plastic, wrappings, you're not yet sure if it's a drug. Of course, it's the first hint, it's a suspect, but then the drug or maybe the content of the drug can only be proven from the toxicological analysis. So don't be surprised if I keep using suspected drug toilets. So as you can see, in one of the containers we did find over 38 packages, and then there are also some others where 60 packages, then 39, 7, 2, and 2. So as you can see, it depends on what the person has ingested. That's one. What the person has already excreted, because then like I said, they are held over 72 hours in police custody. But the moment the container comes to the institute for us to analyze, it's very, very possible that maybe all the drug containers or maybe all the packages that were ingested haven't yet been excreted. But like I said, they cannot be held for over 72 hours because then the risk of rupture is also increased after 72 hours. So these are the drug toilets that we got within the 72 hours. So sample cases, just to give you, what the cases look like. A 21-year-old male body packer was taken into custody after being suspected of having ingested illicit drugs. So the suspicion is there. Of course, someone comes to the airport, The police looks at you. Of course, they have a suspect profile, or they suspect something. Or, for example, if it's your first time to do it, you're also a bit, agitated or uneasy. Then the police just say, okay, you're coming for check. So randomly, not necessarily saying, okay, I had a tag saying I'm a body packer or I'm carrying drugs. You don't do that. So the police just say, okay, randomly a group of everyone traveling through the airport, and they say, okay, we are picking, let's say, 2 or 3 or 4 or 5 people, and then we take you for screening. So on careful examination of the controlled drug toilets from him, a total of 60 oval-shaped drug containers, each measuring about 4 by 1 centimeter and a combined weight of 648 grams of drugs were found. The grayish containers were tightly wrapped with transparent plastic cling films with a label, and all containers appeared intact. So that was good for the transporter, for the person, because they were not yet ruptured. Otherwise, you can imagine the toxicity that could have arisen from, let's say, if this is 648 grams of heroin, for example, or cocaine. So these are the containers. Of course, the wrapping could be anyhow. Some prefer, a tablet form. Some prefer this oval shape. Some prefer something circular, depending on what the person or how the person wants to do the wrappings. Another case, a 24-year-old male taken into custody again on suspicion of body stuffing, of course taken from the street, provided 3 separate drug toilets that were later carefully examined at the Institute of Legal Medicine. On examination, one of the toilets contained a total of 7 suspected drug balls, or drug containers, or drug packages. These were round-shaped, tightly wrapped with plastic cling films, and each measuring about 1 centimeter in diameter. So most of the times, especially for the street dealers, the body pushers and body stuffers, they try to make that as small as possible, tablet form and tablet size, for them to easily swallow the tablets when confronted by the police. Toxicological analysis done later revealed that the content of the drugs was cocaine. So don't do that, then you've lost your evidence, and the person is leaving custody. Just to wind up, we had in the 40 months of the study, of the analysis, we had excrements from 72 individuals, and I must also mention that it's also possible to have multiple excrements from one individual. So let's say if they're taken within the first 6 hours and they want to go to the toilet, they are given the camping toilet or the toilet box. And then in another 6 hours, they want to go to the toilet. In another 6, they want to go to the toilet. So it's not surprising if you get maybe two or even more, or even say, let's say 6 or 5 or 7 drug toilets from the same individual. And of course, the more you have, the more the chances to find something if it is indeed there. So not all suspects that are taken into custody have actually ingested something, but of course, that can be in a smaller period of time. The 3/4 of the suspects were Africans. I showed that on the graph. And, we tried to think about what the explanation could be. And as you might all know, there was a very, very big influx of migrants around 2015, 2016 to European countries, Italy, Germany, especially from African countries across the Mediterranean. So it's very, very likely that most of the cases, when you look at the profiles of these individuals, you find that they are very, very young people. And when you look at the origin, it matches totally to what to the profiles we saw from the countries of origin. So that could be one of the explanations for the increase in the number over a smaller period of time, but also the profile, the country profile of these suspects. Sorry. Then the positive drug toilets were only in 13 cases, and in these toilets which are positive, only 46.2% were from individuals of African descent. So when you look at the number of suspects, the Africans were higher, but the positivity of the toilets that went slightly lower, because not only people of African descent use this, but like I said, this is something that is based on trust. So if I am the boss and I want to give you drug packets for transportation, I would prefer someone that I speak the same language, we have the same culture, and that I can easily influence, because then all that I even know. So if I know that you're in really, really financial need, we speak the same language, I know your country of origin, I know your network, it's easy for me to work with you rather than working with someone of a different origin, for example, different language, different way of thinking. So majority were, of course, from the same country. From what I just explained, it's a trade that is based on trust. And the common drugs involved in this study were crack and cocaine. In the body stuffer, or the low cost and smaller quantity groups, while heroin was more prevalent in the body packer group. But again, like I said at the beginning, it depends on the cost of the drug involved, the quantity of drug involved, and the distance over which this drug must be transported. So in all these cases, the 13 cases where the toilets were positive, all the drug toilets were, all the drug containers, all the drug balls were intact. And of course, from that we didn't find any case of toxicity. So no patient, no suspect was taken into hospital. And of course, where longer times in custody are planned, we try to avoid a longer period of time, because then, like I said, if someone has really ingested the drug containers, the risk of rapid I thank you for your kind attention, and of course, if you have any questions, I'll be happy to take the question. But like I said, you can read the full article for more information. Thank you so much. Okay, so Joseph is maybe outside, so I will take maybe any questions. I don't know how much time we have, Oli. Maybe. Huh? Good. So any questions? Otherwise, we can proceed to the next presentation. Do you have a second microphone? Hi.
Thank you. I am Muhirwa Alphonse. I really want to know what methods do you use to get to suspect?
You mean in terms of getting them on the street, catching them on the street?
Yeah, or on the airplanes.
Okay, so like I said, there's no specific method of getting the suspect. It's best. It's most of the time you have the suspect. You're suspecting someone because of the way they are behaving or the way they were acting, or sometimes you already have a tip-off. For example, most of the cases where you have tip-offs are cases where long distances are involved, and high-cost drugs are involved, then you have a tip-off from maybe someone, maybe if it's two drug cartels, and then one, reports the other. So they give a hint to the police. So basically, like I said, the most important thing is having a suspect, and then randomly selecting the suspects, and then testing them or screening them. So, but there is ideally no specific method of saying, okay, I will look at you and say you're a drug dealer. So it's suspicion, and then take that person into custody, or even temporary custody for the screening and the searching. But like I said, most of the times it's also based on the tip-offs from rival cartels, or maybe rival drug dealers, which will say, okay, I saw cartel one, giving, let's say, 1,000 packets of heroin to this woman or to this man, and then they call the police, or they call another investigative, the prosecutor's office, and say that person is a suspect, or maybe screen that person. But there's no specific method of saying, okay, I will look at someone in an airport hall, say, okay, this person is a drug dealer. I hope that answers your question.
Thank you, Dr. Mushuma, for this nice presentation. It is a good contribution to forensic sciences. On the list you provide about the country of origin, I was expecting to see at least one country from South America. As you know, it is a place where the drugs are on that.
Well, I think that's a suspicion, but like I said, we analyzed what we got. Drug trade is everywhere, be it in South America, be it in North America, be it in Mexico, be it in Africa, be it in Europe. But maybe most South Americans don't come to Europe, for example. Maybe they go to the US. That could also be an explanation why we didn't find many South Americans in Germany. Maybe they prefer to go to the US.
Or to pass through Africa by crossing Atlantic Ocean.
Through Congo, from Brazil and DRC, and then to Rwanda, yeah? And then go to Germany. But I think that could be the explanation, because you are looking at, the best possible way to do the transportation, the easiest route, and the most rewarding route, and the most rewarding country. So it's not surprising, for example, if you say someone from Mexico is not going to come and sell their drugs in Germany or maybe in Spain. They would rather prefer to go to the US because it's shorter, there's a bigger market, and it's even, not time consuming because it's so close. So I think that's one very big factor why we didn't see many cases of South Americans in Germany. But of course, I totally agree with you. Drug trade is everywhere.
Okay, thank you very much.
Welcome. So maybe I'll take one question and then we go to the next presentation. Jafet.
Thank you, Doctor. I was asking, apart from this body packing, body stuffing, and body pushing, are there some cases where they will open the abdomen and they put in the packs and for transportation? From maybe the literature or other cases, apart from your cases here?
Yeah.
Are there some cases where they will open the abdomen and they put the packs? That's my question.
Of course, there are some cases in the literature, but of course it's not very common, because then someone will say, okay, I don't want to anything invasive or maybe surgery, but there are some cases in the literature, yes. But of course, like I said, they also, of course, especially for the body packers, where very large quantities of drugs are involved, sometimes it is forceful, so you don't have an option, or you don't have a choice. So someone comes and says, okay, this is the drug lord, or the cartel boss, and comes and says, okay, I picked you from the street, you're a woman, you're a man, and they say, okay, we can do whatever we want. If you don't cooperate, we kill you. So sometimes it can't be anything, but they're also very, very careful not to weaken you, because then you have to do the delivery. So So they will say, okay, if we operate on you, if you open your abdomen, will you be able to, cross borders when you're sick? But there are some cases in the literature, and they can do anything they want, especially in cases where drug cartels are involved. Because again, like I said, you've heard about cases when someone doesn't cooperate, they're either killed, the family is killed, the children are killed, or maybe even kidnapped to force you to cooperate. But like I said, there are some cases in the literature, yes. Yeah, thank you.
So, thank you, Herbert. We are now doing the talk of Janvier. He's actually the third in line if you look on the program, but we are still now adjusting the presentation, the second presentation, so it will come afterwards. So, thank you, Janvier.
Thank you very much. Good morning once again. I'm called Janvier from Rwanda Forensic Laboratory. I'm going to present to you about sudden death by pulmonary thromboembolism. What you are seeing there is like overview of the presentation, and when we talk about thromboembolism, pulmonary thromboembolism, we think about circulatory system, and whatever you are seeing there, it's all about the effect, the location, and the examination. Everything is about the findings, the treatment, and the risk factors that is involved while we deal with pulmonary thromboembolism. Whatever you are seeing there, it's we think about arteries, veins, heart, and lower limbs, whereby we think about the whole circulatory system will be affected when you are suffering from thromboembolism. As background of the study, it's all about we get the body when somebody passed away. They brought the body at forensic medicine in Rwanda Forensic Laboratory. We do the autopsy, and whatever we're going to see there, it's about the autopsy performance that we get the results, and from there we get that the cause of death was about the link with thromboembolism. With background, it's all about the death investigation, and where they did both dissection and get results like thromboembolism as the cause of death. But historically, it has been performed around the world and in different centuries. Pulmonary embolism is a commonly potentially fatal cardiovascular disorder, and it can be treated and controlled at any time when it is declared annual. This case have been retrieved from the case we conducted from 2018 to 2019. Its number of cases in total these 2 years is about 1,135, and we got that number of cases detected as natural cause is about 111, whereby we counted the cases detected with pulmonary embolism is about only 7 cases in 2 years. This is shown there with statistics, whereby you have pulmonary embolism of 7% and other natural causes apart from thromboembolism 93%. So we go with some definitions whereby we're going to talk about circulatory system and pulmonary embolism. By circulatory system, it's composed blood vessels, where we think about, as I told you from the first and second slides, I said arteries, heart, veins, and the heart which is like a motor used to pump the blood to orient this in vessels and arteries. And pulmonary embolism is usually a sudden blockage in lungs artery, where it happens when the blood is clotting and comes from the legs up to the other side, depending on that circulation of blood in the body. We think about thrombus and embolus. Thrombus refers also to the blood clot that formed inside the circulatory system, impeding the blood to flow the system. Whereby embolus also is included in thromboembolism, whereby it refers to blood clot. It can be the fat or other dead tissues or bubbles that carried out in the whole system, in the movement of the blood circulating in the body. I did this study. I am presenting this one with some objectives because it has been discovered that, as we saw, that it can be treated and managed at any extent. And as long as you have such cases, I try to say that you have to see like key factors that is lead to thromboembolism. I have to recall some prevention measurements and treatment so that as long as we get something, signs and symptoms, that we can try and manage it at all. Pulmonary and postmortem examination. As I said, someone getting pain, getting treatment, then after passed away. At that state, after that state, they brought the body, saying what was the cause of death. Suddenly, person passed away, and you want to know what was the cause of death. So they brought the body for postmortem examination. So the examination is done systematically. We do the external and internal examination so that we can join this information to provide full and accurate information about the cause of death. Apart from there, we had not to negate information from families. Medical history, medical background of the body, medical background of the person, why it went for treatment, you have to manage it, and the personal background, where the family talk about the working system, the work they did, the time and what. So this information also have to be considered so that it can guide and help to provide full information. This case I'm going to talk about is about someone who used to be involved in an accident, road traffic accident. He went for treatment, and after backing from the hospital for that health facilities, it passed away while he or she didn't came for the last checkup. It's a female for 60 years with that length and the 68 kilo. He went for medical, as I said, and was involved in accident, whereby transported for the hospital, then get the treatment as well. But by the time they said, and she went out of the hospital, waiting for the last checkup. Before coming for checkup, she passed away. And the family said that, complaining that he had those problems, dizziness, shortness in breath, pain, chest pain. That is the information from the family, as I talked from the first, previous slides. And at that state is where they brought the body for the autopsy, where we systematically perform that autopsy. The external and internal have been performed, and now we're gonna see what have been detected in external, then followed by what we did, we saw by internal examination. We saw that the petechia, those are dots and spots detected in the eyes, conjunctiva and sclera. Those neck vessels were swollen. There are also base scar wounds, whereby as he passed a long time in the hospital, he was sleeping and sit for a long time, so that that development, that wound, severe wound, have been detected on the buttocks. The left leg was amputated below the neck, whereby it had been, by that accident and the treatment, it had been discovered that he passed away and passed through the hospital. Multiple skin gloves because of those abrasions and some those wounds from there, they used to, while treating, they used to treat the body with these scars treated. After external, we did internal, whereby we saw that those lungs were severely with ingestion, congestion, and multiple thrombi in the small pulmonary vessels, especially in middle and the lower lobes, and the right lungs with consolidation. That was because that consolidation is because of the lungs were like suffering for that blockage at any instant with the pressure and the heart failure, while it used to pump and nothing happened. It loses the oxygen while no oxygen entering the lungs. There were extensive thrombus in pulmonary trunk extending to the left, right artery. It had like broken two ways at the same time, where we call it cerebropulmonary embolism in that artery. From there, the body discovered that he passed away. He died by cardiopulmonary embolism. The heart was affected, lungs were affected. From that case, we got that the body passed away by that issue. As I said, we should discuss about these factors leading to pulmonary embolism. From different literature reviews, we heard that we have some. As I said, these clots coming from the legs, from the first side overview, I said that it passes through the secretion from the lower limb to the upper side, where legs, heart, and other blood vessels and arteries are affected. And this also, the surgery causes in healing process and other lost parts, the losing part, it causes also these problems of causes this pulmonary embolism. If medical condition disease like and lung disease like myocardial infarction and atherosclerosis, those are the factors that can contribute to pulmonary embolism. The broken hips and the legs, as we saw that the other one have been involved in accident, missed a part of leg, so that they used to do such operations. And it was like that case where he lost the leg and other trauma that should come and contribute to thromboembolism. The pregnancy and why your pregnancy and childbirth, they have seen that the risk comes at time, about 6 weeks after childbirth, where it's because that complication you get that something the obstruction of something. While having that valve, this complication also should contribute also to the production of this thromboembolism. Not moving long period. That is also the risk when you take a seat for a long time, when you get a sleep for a long time without moving, also that can contribute to the production of this thromboembolism. Whereby I showed you from the first slide where I had person sitting, airplane, and someone who were also moving away. Age also, it can contribute. As long as you get age, you come older, you become like physically easier. You still like do such sport, stronger action, as long as you become age, you are at higher risk of getting thromboembolism. It doesn't mean that as long as you come at age, you have to make like sports sometime or accordingly. The obesity. The obesity also contributes to the production or to read at risk of pulmonary embolism. As long as you are obese, it's all about the fat. Vessels and arteries comes like narrow, and this circulation is also a problem.
There's 1 minute left now.
Yes. You increase the smoke, you have to decrease the smoke. And these symptoms also appears while as the person is suffering from thromboembolism. You get shortness of the breath, pain, pressure in the chest, dizziness, temporary loss of consciousness, and coughing. You prevent all of this by doing support. You with smoking. You go for treatment. You manage health problems and so on. You can also have dust test, blood test, duplex, magnetic resonance, venography. Those are the kind of tests they did while they are treating this kind of embolism. Treating that kind of embolism, also you have to locate, while you did the other thing, you have to locate and the location of the clot, whereby you detect you with your target. Thrombotic medication to dissolve the clot, anticoagulant to impede clotting, and surgery where those clots are detected. Thank you for your kind attention. If there is any problem and supplement, you are welcome.
Yes, thank you, Janvier. We don't have time for questions, so if you have any questions about this matter, you can go to Janvier after or somewhere in the break.
Thank you.
Okay, the next presentation, it's about pica. So, Tony, you can go on.
Okay, so a very good morning to every one of you, and welcome to this year's summer school. I'm called Tony Okecha, and I am a pathologist from Uganda. I work at the Mulago National Referral Hospital and the Uganda Cancer Institute. So, apologies from Dr. Male Mutumba for not making it, and Dr. Sam Kalunji for not making it to this year's summer school. They had some engagements, but in their stead, I'll give the presentation. So, we are going to talk about something that we call pica. It is something that most of these cases that we're going to discuss were mainly incidental findings at postmortem. I did include some images. I don't know, they might be graphic for some of you, but since we are talking forensic medicine, I thought it would be imperative for us to include those images. They are actual postmortem images that we got from these postmortems. Okay, so pica is a psychological disorder usually characterized by an appetite for substances that are largely non-nutritive. So basically it means that people tend to consume food, rather substances that are not food, for example. So you'll find that the most common things that people tend to consume that are not strange, it may be the setting here in Rwanda and back home in Uganda is usually soil. There is a particular kind of soil, we call it bumba, back home in Uganda, that people usually consume. They even sell it off the markets, and pregnant women usually tend to consume it more. So the pica that we're going to talk about today is derived from cases that are rare and strange, okay? So unlike soil that people usually take, these things are usually strange. And the basis for this was that there were no cases that were reported about in my setting in Uganda. Oh, sorry. So the first case that we're going to talk about is that of about 7 to 8 years old Ugandan girl who had a non-psychiatric disorder. So it was not elaborated by the parents because probably she was not receiving psychiatric care. So they did know that this girl had a problem, but they didn't know the psychiatric problem that she had. So the parents reported that she had the habit of eating rare substances and was eating her sponge mattress away. So she would break large chunks of the mattress and actually consume it. So I think you can agree with me that those are very rare things that people rarely do. So at autopsy, we try to summarize most of these things. She was noted to be wasted. The wasting is basically coming from the thing that she's ingesting. Instead of ingesting food, she's ingesting these non-food materials. So she had concentric scars around the wrists, and this is probably due to the parents and the attendants trying to restrain her from actually consuming these substances. Internally, pale viscera, and in the stomach we found about 500 grams of undigested sponge. That is quite a lot, and I don't know, as I told you, those are the images that was taken from the stomach of this young girl, filled with sponge. So you can see how strange such occurrences are, but we tend to find them occasionally at postmortems. So before we go to the second case, in this girl, the sponge was an incidental finding. It wasn't the actual cause of death. We did find other things in the lungs. We thought she died of pneumonia and not the pica. So this was something incidental that we found. So quickly to the second one. This was also an adolescent male who had been admitted in a psychiatric hospital in Kampala. They didn't tell us which exact hospital. So you can relate from these two cases that most of these people actually have psychiatric illnesses, okay? So probably if we do get a larger sample size, we may tend to link exactly which psychiatric illness that could be commonly associated with pica. pica that we are seeing. So, like in the first case, this person was wasted, many scars on the back, and in the stomach, we did find about 22 grams of undigested grass particles. So, you do agree with me that in some of these African countries, there are some grasses or even vegetables that we are known to eat, okay? So, if you find something that doesn't fit those grasses that are known to be eaten by the population around, so that's when you'll think about something very, very strange. So, as I was saying earlier, the type of grass found in the stomach did not fall in the different species of the Uganda. So, if you can see, I don't know how clear the image is, you can see that there is grass that is lodged just at the larynx, and it's actually occluding the airway. So in this case, in the further examination of the body, we didn't find any other maybe cause of death that could be attributed to this patient, and it was basically the choking by the thing that this person was ingesting that directly led to his demise. So this is basically another image that we're trying to get. You can see we are trying to open the epiglottis and right to the trachea so that we see what was inside. So this part is now the opened trachea to see if there was anything that was further down the trachea, but it was only at the epiglottis and occluding the airway from there. So we'll now look at the third case, and this one I think was the most rare because it's an adult male. This one lived on the streets of Kampala. He was basically homeless, and the body was just picked off the street and brought to the mortuary. And you know, when they find someone just by the roadside dead, they usually don't provide any clinical history. At least in the previous cases, these people had attendants who could give us a little bit of the history. This one was just picked by the police on the streets and brought to the mortuary for a post-mortem. So at autopsy, it revealed a wasted, unkempt adult male, and significant findings were in the GIT where metal objects were found in the stomach and the intestines. So you can see that this time round, this person was actually ingesting those metallic things. So this was an image that was taken of the stomach after we had opened and looked at it. Pins, keys, mostly keys and other metallic things, especially those small things, are what we saw in this person's stomach. Like in the first case, this also happened to be an incidental finding and not the actual cause of death, because we also found that actually this person had died of pneumonia based on the state of his lungs vis-a-vis what we found in the stomach. So this is just a further image and a brief discussion about pica. We are saying it is the persistent, culturally and developmental inappropriate ingestion of non-nutritive or non-food substances. Common in small children, the mentally retarded. With the small children, they are trying to just experiment. So those ones usually actually do not consider it as much as we could consider it in adults, okay? Kids usually are just playing with some of these things and accidentally they ingest them. But for adults, it is something that is done by choice. So, and in pregnant women, as I had earlier said, a lot of the women back home, especially when they're pregnant, tend to ingest soil. They actually buy it over the counter and in markets, and society actually is okay with it. In medicine, we also say it is usually associated with iron deficiency anemia, where people crave for such things and they ingest soil. Then it occurs throughout the world, and this is commonly occurs in the form of geography, which is the deliberate ingestion of soil. Then the thing that we've talked about, the cases we've illustrated are the rare forms and not the common forms of pica like soil. And that is what actually intrigued us to write about this case series. And the commonly ingested non-food materials, soil, clay, some people eat pepper, others usually take paint coatings of the walls and ingest them, strings. Some people, especially people with psychiatric illnesses, with severe depression, usually pull hair off their heads and ingest the hair. I was reading an article about someone who actually just found a lot of hair in the stomach. So those are the common things. Children are rarely brought for psychiatric treatment for the isolated problem. I told you earlier, it is usually accidental in kids, so we don't usually put a lot of emphasis on that. Geophagy, as we said, soil is the predominant. Different causes that are claimed to predispose one to pica, usually iron deficiency anemia for the soil eating, then OCD, nutritional deficiencies, but the most important things are the mental health conditions. Especially for these rare cases, we tend to associate them with mental illnesses, right from ID, intellectual disabilities, schizophrenia, OCD, which is obsessive compulsive disorder, and unfortunately, we do not have any lab tests that we are going to carry out for these. We only just to diagnose this condition. Most of these things, we usually just see it at post-mortem. For the few cases like iron deficiency anemia, we usually easily detect it. Pregnant woman has gone for antenatal, do a complete blood count and probably detect this. But in the rare cases, there are no lab tests we do. So in conclusion, we know that pica for soil is common, which is okay, but there is need to document the prevalence of pica in the Ugandan population and possible associated factors. And maybe there is a role for the forensic autopsy pathologist to play in this process. If we can document especially all the rare forms that we are seeing, then try to correlate them with the clinical manifestations, the mental health manifestations of these patients before their demise, then probably we could be in better position to help them. Now or later.
First, thank you for your talk. And we may have time for one question, and then we will do the first break. We're running a little bit late, so we introduce a break now, and we will have the other talks afterwards. So, any question about pica? Not that I can see. If some questions will arise, just go to Tony and ask him directly in the break or afterwards. Okay, thank you. 50 minutes. Okay, 15 minutes are over. Please come back inside so we can start. So next presentation.
Female sex workers.
Okay, welcome back from the break. The next presentation will be done by Samuel, but he's not here, but he prepared it before. He's in California now, so it's about the same weather, I think. And so we can just play it, and there will be no questions afterwards, of course.
Good morning, everybody. My name is Samuel Habimana. Good morning, everybody. My name is Samuel Habimana. I'm a PhD student from Marinda University, United States of America. I'm so glad and so happy to be part of this 9th Interdisciplinary Forensic Summer School, which is holding here in Nobleza virtually. I'm going to present the research which is called the profile of risk factors of injecting drug use among the sample who are at high risk person for HIV, MSM, female sex workers, injecting drug users in Kigali city. This research has been conducted by Samuel Habimana, Dr. Zephon Rista, Susanna Montgomery from Marinda University, School of Behavioral Health, Emmanuel Virachaza from Prison Fellowship Rwanda, Dr. Kagaba Aphrodis from HDI Rwanda, Albert Nshimdayigijimana, Stefan Jensen, Professor Eugene Rutempesa from University of Rwanda. This presentation is sum up with the introduction, gap, research objective, methods, result, discussion, recommendation, and conclusion. Quickly, to introduce what is our presentation, normally in Rwanda, alcohol use and substance use, injecting drug users, and depression, it has steadily increased in the past decades in Rwanda. I think it's a problem because it is increasing more in youth and teenagers. More youth and teenagers are involving in those behaviors, specifically in Kigali city. Rwanda, as the country which has been experiencing genocide, with different research shows that there is a high rate of trauma, specifically PTSD. But we need more research on that. We need more research on mental health. There is little data, little research on injecting drug users or the people who are high risk of HIV on their mental health, specifically injecting drug users. The research is really low. To address the gap, we explore the relationship between social demographic, various types of substance use, depression, and intravenous drug use within this sample of injecting drug use. This study has been taken in Kigali city. To our knowledge, this is the first study that has been conducted in Rwanda and even in Kigali city. As said, this research has been conducted in 3 districts of Kigali city. We had 2 sites, HDI Health Development Initiative headquarters. It's near here at near Chichichiro Centre. Near Chichichiro Center, it's a little miles from the main road to HDI headquarters. And other side were at Nyakabanda Health Center. It's also a sub office of HDI, which is located in Nyakabanda. We have been using snowboarding sampling to get those participants of this group. You know, it's illegal behaviors. It's not easy to get those participants, but snowboarding sampling was a good method to get together. 418 participants were participating in our research, whereby 151 were injecting drug users, others were not. We have been using the measurements, including back depression inventory, assessing depression, the demographic questionnaire, mini neuropsychiatric interview, brief one, which were assessing alcohol and drug. We have nurses who were in both sides, I mean, HDI headquarters and Nyakabanda Health Center, who were testing a rapid HIV test immediately before the participant involving in our research. And also this research has been granted by RNEC, Rwanda National Ethics Committee. Let's talk about the findings. In our research, injecting drug users were tend to be single and male and sexual minorities. When I say sexual minorities, kindly understand MSM, male having sex with a male, and bisexual. The transgender participants were only the group that were more likely to be injecting drug users than non-injecting drug users. About the social demographic variable, the overall for both non-injecting drug users and injecting drug users tend to be educated. I mean, they have secondary school education. This is not surprising because in Rwanda, the people, specifically in Kigali city, who are less than 30 years because of different program of government of Rwanda, they complete their secondary school. Regardless of injecting drug users or non-injecting drug users, our research shows both of them, they have moderate to severe depression, whereby injecting drug users were scored at 1.5% and non-injecting drug users were 65.3. About the substance use, majority of non-injecting drug users were consuming alcohol up to 71.1. They will use they have been using it for alcohol, for substance use. I mean, they use more different substance use. And non-injecting drug use were also like to, were like to drink alcohol, beer, and hard liquor. And another things which I want to talk about, among the injecting drug use, most preferable to use heroin. Heroin in Rwanda, in Kigali city, we call it mugo. I think the participants of this conference, they understand mugo probably compared to heroin is. The female sex workers who participating in our research, 83.3, all of them have been using mugo. Homosexual, 100%, they have been using bisexual, at least 90.6. You see, this is a problem. Result from female sexual workers, all of them, at least 60%, have been getting secondary education, and also there tends to be a divorce and widower up to 49%. And regardless, I want to stress here, regardless to injecting drug use, most of female sexual workers are being moderate to severe depression. That was not statistically different, means being female sexual workers who injecting drugs and being female sexual workers who not injecting drug use, there is all of them, they tend to have severe to moderate to severe depression, according to our Beck depression inventory. About sexual minorities, here in our research, about the sexual minorities, 166 about sexual minorities while non-injecting drug use, 111 were injecting drug use. Among of them, among the sexual minorities, injecting drug use were statistically more likely to be single more than those who are non-injecting drug use. Indeed, among sexual minorities, injecting drug use were statistically more likely to be moderate to severe depression. It means that being sexual minorities in injecting drug use has statistical significance contributing to injecting drug use. As a p-value you see here, it is significant. Let's say about discussion and recommendation. We have seen that there is a relationship between several social demographic characteristics, like being single, male, sexual minorities, and injecting drug use in this population who are high risk of HIV. Indeed, the result revealed that depression were higher in all participants of this study, but in injecting drug users, the depression were high than others. Without focusing on this research, we can say that the high risk of behavior in our non-injecting drug user participant is validated in their high alcohol use, poly-drug use, and HIV compared to injecting drug use. Clearly, group needs attention as well as have too high rate of depression. We have set some recommendation. Probably this recommendation can be addressed to Rwanda Ministry of Health, RBC, Mental Health Department, probably HDI, Health Development Initiative, where funding or implementing this research, University of Rwanda as well. We found that being sexual minorities and depression are the characteristics of increasing personal likelihood or risk factor of injecting drug use. Probably even the police, this recommendation is for them. Effective intervention will need to address those risk factors, even deeper ingredient social factors in Rwanda culture that stigmatize both sexual minorities and mental health. It's obvious that being sexual minorities, it's not accommodated in Rwandan culture. And also seeking mental health services also it's a thing which we are not yet reaching, because we are scoring in Rwanda, we are scoring high rate of low accessing to mental health services in Rwanda with different risk factors, including our Rwandan culture. Indeed, mental health education programs are urgently needed in this population, specifically injecting drug users. Given an experience, normalizing the stigma of seeking care for mental health is going to be important for any group of risk of HIV, but especially in injecting drug users. We have successfully used community resilience model skills training as a non-stigmatizing intervention in Rwandan population. We suggest that CREM, or community resilience model, can be using in this population who's seeking mental health treatment, because it's a model which is accessible, adaptable, and affordable, which can be used everywhere. And the results we got in the study we did in Rwanda has shown that this model can be used to help those people who have mental health problems, specifically this population. The further research, indeed, we recommend that the further research can rigorously test the use of this CREM, community resilience model, for this context of injecting drug users, MSM, those people who are high risk of HIV, to see that their mental health problems can be significantly decreased because of this mental health intervention. To conclude, the results show that depression symptoms are irresistible problems that should not be disregarded among injecting drug users. That's why mental health education programs are urgently compulsory in this population.
Good morning. I'm Dr. Luis Mnezero. I just completed my M.Med in anatomical pathology this year in the University of Rwanda, and I have prepared this case with Dr. Valenci, the forensic medicine division manager, even though he's not here, but we have worked this together. And I'm going to talk about the lateral ventricular neoplasm associated with the fatal intraventricular hemorrhage. So those are outlines. We will go through the case, then we will see what the literatures are saying about this case, and then some conclusion. So the case was a 19-year-old male who was previously healthy. He was playing football with the other teenagers in the village, and he slowly sat down, collapsed. They immediately transported her to the hospital, but he arrived at the hospital already died. They referred the body to the Rwanda Forensic Laboratory where we did autopsy. And during the autopsy, on external examination, there was nothing unremarkable. And even on history, the guy doesn't have any history of hypertension or other risk factors. And on opening, other systems were normal, heart, intra-abdominal organs, everything were normal, and the positive findings were found in the brain, where we have found bilateral hemorrhage in both ventricles and neoplasms 2 and 2.5 centimeter diameters. So at the Rwanda Forensic Laboratory, we don't do histological diagnosis due to resource limited. We didn't do it for this case, and when we need it for ambiguous cases, it refers to transfer at the King Faisal Hospital, and it is too expensive, they can't afford it. So this is the picture. I don't know if you can see it, but the picture A, it is a coronal view of the brain, which is showing hemorrhage in both ventricles. I tried to use those arrows to show you those neoplasms. So, in the literature, intraventricular hemorrhage is rare. It accounts almost 3% of all intracranial bleeding, and specifically, it can be primary or secondary. The primary intraventricular hemorrhage is defined as the bleeding within the ventricle, which is not associated with any intracerebral or intracranial hemorrhage, or if there is a bleeding in the ventricle or within 15 millimeter. The primary intraventricular hemorrhage is most recent in preterm because of the risk factor being prematurity, and the secondary intraventricular hemorrhage is the most common in the adult population, and it is defined as the bleeding which is associated with any form of intracranial hemorrhage. So the secondary or primary intraventricular hemorrhage, we said that is very rare, and the association with neoplasm is exceedingly rare, and any type of neoplasm can be associated with the bleeding either by rupture or by the different mechanisms growing rapidly and so on. And most of them can be meningioma, ependymomas, papilloma, or it can even be metastasis like melanoma, which has metastasized there, or choriocarcinoma and the other neoplasms. So the mortality due to intraventricular hemorrhage increases with the older age and the amount of the blood within the ventricle. So those are predisposing factors. Because the primary intraventricular hemorrhage is mostly seen in pediatric ages, especially in preterm babies, and the secondary ones, it is mostly associated with the neoplasm, but when you have some malformation, exposes you to have this bleeding. So I tried to come up with some some cases that have been published. There are not many, but I saw like 9 cases of meningiomas, different variants of meningiomas that have been published to be to either causes death or the patient survived depending on the amount of the blood that was there and the volume of the tumor. And this case, this is the paper which has been published. Many researches has been conducted and many debates for different scientists has been done to determine what can be the amount of blood in ventricle that can be leading to the death. And some studies have found 20 milliliters to cause death. Others has found 30, 40, 60, but the minimum I have found is 20. That can cause death. And there are many techniques that can be used to estimate the amount of the blood in the ventricle. And this one is one which is used when you are using a CT scan, but later it has been adopted even on ultrasound, especially for preterm babies, and it grades the intraventricular hemorrhage into 4. And the fourth one is the more severe, where the intraventricular hemorrhage is associated with the intracerebral hemorrhage. Because the severity of hemorrhage depends also on the location. When you have bleeding in the third or fourth ventricle, it is more severe than lateral ventricles. That's why there is another grading system which is grading to mild, moderate, and severe. So as I was saying, many cases are found are meningiomas, and this is a case of 46-year-old male who had a sudden onset of headache within 5 hours, and he was immediately transported to the hospital where he has been diagnosed on the CT scan. You can see the first image is a CT scan which is showing the neoplasm with the calcification which is associated with a moderate hemorrhage in ventricle. And on histology, it has been diagnosed as transitional type meningioma, which is a grade 1, not aggressive, but because the bleeding was not too much, after 6 months he was free of any symptoms, and she was doing well. So this case was also found in Germany, and it is a 57-year-old woman found unconscious at home, and on examination she doesn't have any signs of trauma. On the CT scan, she has a mass in the lateral ventricle with hemorrhage, and at autopsy you can see the mass which is surrounded by hemorrhage, and even there was bleeding even within the center of the plasm, and the mass was big, measuring 4 centimeters. And then on histology, it was an angiomatous meningioma. You can see the vessel and the whole pattern of the classical meningioma. And because the vascular were more than 50%, it has been diagnosed as an angiomatous meningioma. So this is another case. So those 2 cases were the bleeding which were associated with the neoplasm, but you can have primary or secondary intraventricular hemorrhage without a neoplastic process association. And this paper, which has been published in Forensic Science Journal, it has published 2 cases of sudden death due to intraventricular hemorrhage without association of neoplasm. And the first case was a 26-year-old man. He was found dead without witness. And during autopsy, they have found vascular malformation. And this is the histological feature which is showing a thick and thin irregular vasculature. which in favor of vascular malformation within the ventricular wall. The other one also was a 39-year-old man who was admitted to the hospital in a deep coma, and he died within 7 hours of hospitalization. They did the CT scan, which showed hemorrhage in both ventricles, and at autopsy they found hemorrhage and blood clot within ventricles. On histology, there was bleeding and thin, even thick walled blood vessels with irregular vasculature. This was also in favor of vascular malformation. So as conclusion, intraventricular hemorrhage can be primary or secondary, and the intraventricular neoplasm are rare, and it is exceedingly rare to have intraventricular neoplasm with the association with the intraventricular hemorrhage. Most of intraventricular neoplasms are benign and can be diagnosed either by imaging like a CT scan or MRI, but also can be found in autopsy, and the diagnosis is confirmed by histology to determine whether there was a neoplastic process you can see with your eyes, and then histology can confirm which type of neoplasm, or if there is other malformations. That's why in Rwanda, we have Rwanda Forensic Laboratory is doing a good job in determining the cause of death as well as the manner of death. But if it has histology department that can support them in daily practice, that it can be good. So this is what I have prepared. Those are references from those cases I have presented, and thank you for your kind attention.
Thank you very much, Dr. Mnezero. Always, if you have a question, you have to keep by the end of the presentation to go through those questions. So our next presenter is Dr. Murangira. He will take us through DNA data bank towards vision of justice, legal and ethical issues. Dr. Murangira, is he present? If he's not present, we can go direct to Nshimiyimana, our next presenter. He will take us through DNA analysis in identification of suspect in a murder case. It's a case study. Thank you very much.
Okay, thank you very much. It's great to be here to talk a little bit something that we do a lot at the Rwanda Forensic Laboratory, which is DNA analysis to help link or exclude suspect and victim to the crime scene. So our presentation is based on a case study, which is the DNA analysis in the identification of suspect in a murder case. It's a case study. So the case study is summed up in this summary that you see. We go through, we see some little background, and then we dive deep in our case study, and then material and the method, we see the result, and then finally we conclude. So first of all, here is some little background, which is there is this DNA testing is one of the key methods currently used to link or exclude suspect, victim, and crime scene. So basically, forensic scientists process DNA samples using a method which is called STR analysis. So the STR stand for short tandem repeats. So as you can see on the picture, here is a genetic analyzer with a computer on a side used to process or monitor information gained from the genetic analyzer. So here is the basic idea is usually the STR analysis. It's the method currently used by the scientists to process and analyze DNA samples. It's based on rito structures of DNA sequences scattered through our genome. They are usually variable, and it's rare to find them being similar from one individual to another. So as you can see on the picture, on the first array we have 7 repeats, for instance, of AATG, and on the second array we have 80 repeats. So it's on those repeats, you see the numbers are different, that we usually identify individuals using those differences in repeats. So the repeat region is variable between samples. As I said, from one individual to another, the repeats are different. I might have like 3 repeats on a specific loci or a specific region of DNA at a specific spot. I may have 7 repeats, while another individual may have like 5 repeats. So it's on those differences in those short tandem repeats that we base our DNA analysis to identify people. So as you can see, the repeats are in tandem, meaning they are together, while the flanking region or the following region is usually constant. So it's on those STR that are variable, we usually base our analysis on. So as you can see, on the first array you have 7 repeats, and on the second array you have 8 repeats. So the profile will look like that. For the DNA profile, you see we have 7 and 8, meaning for the first array you have 7 repeats, second array you have 8 repeats. So now we can dive into our case study. So at the Rwanda Forensic Laboratory, we received a case where a male person was suspected to commit a murder against a female victim. So, and there was a need for DNA analysis to help for criminal justice system. So, as you can see, that male suspect has some blood on fingernails. As you can see on the picture, the blood stain was detected on a suspect's fingernails, but first of all, we have to do the preliminary test to see whether the blood stain was really human. So that's the preliminary test to confirm whether it's human blood or any other kind of blood. So the detector or the investigator wanted to know whether that blood stain on the suspect's fingernail was really the blood of the victim or not. So that's exactly where the DNA analysis came into analysis. But not only we had we had to do the blood analysis on the suspect's fingernail, but also we had to examine or make analysis on the blood stain that were detected on the suspect's sweater. As you can see on the second image, that is a sweater of the suspect, and there was blood stain, which we really wanted to know whether the blood stain was the victim's blood or not. So the DNA analysis was needed to compare DNA profile obtained from the blood stain on the fingernails of the suspect and the blood stain on the sweater, thereby linking them with the victim's DNA profile. So here is the steps that we went through. First of all, there was sample correction. As you can see, we have already our samples blood stain, one from the fingernails of the suspect and the other from the sweater. And then for the victim and the suspect, we had to correct cheek cells or epithelial cells from the suspect and the victim. Then after after correcting our samples, we had to extract our DNA. Then after extracting our DNA, we had to quantify them, to measure them, see if we have enough amount of DNA to proceed to the next stage. That's where quantification come into play. After quantification, we had to amplify the DNA. Next, we have to take our sample to the genetic analyzer and then do the genotyping to get the profile. This is not the real profile. This is a demo just to show how an electrophoregram look like. And then finally, we have to interpret the result. Usually, every DNA profile, no matter how good it is, it has to be interpreted at the end because, as I can say, DNA testing is not perfect enough to just leave it there and not analyze the result that you gain, because even though the DNA analysis can help identify a criminal, there must be other signs or other factors that must come into play to really show or confirm that you've got the right person. So, and the profile will look like that. This is just to help gain the basic idea on the steps involved in the DNA analysis. So, the result we gained the DNA profile of the suspect and that of the victim, of course, and then the DNA typing result obtained from blood stain on the fingernails of the suspect was a mixture, meaning there was two profiles of two individuals on the paper, as you will see. the result, they are here. So we have the DNA profile of the suspect and the profile gained from blood stains of the suspect's hand, and then the profile gained from the suspect's sweater, and then finally the profile of the victim. This is just the first 6 markers that we are showing here. We are not showing a complete profile of 21 markers. So as you can see, for the blood stain, the profile gained from the blood stain from the suspect's hands is a mixture, as you can see. And then from the presentation, as it is colored, you can tell that the profile of the victim is already and the profile of the victim is in the profile of the blood stain of the gained from the suspect's hand. So from this profile, you can see that the profile from the suspect's hands is usually a mixture, and the main contributors are the victim and the suspect. While on the other hand, a blood stain from the sweater is typically the profile of the victim. So there is no doubt that the blood stain from the suspect's hand was from the victim, as you can see on the profile. So after making data analysis, we came to a conclusion that our profiles were matching. So to conclude, in any criminal case where we can gain the DNA profile from either the suspect or the victim or from the crime scene, by performing DNA analysis, you can usually tell whether the suspect has some connection with the crime scene or not. But in addition, DNA analysis is not really conclusive because there must be other factors that has to come into play. Like, for instance, why is the person really connected with the crime scene? So based on the DNA analysis, you cannot confirm 100% that the suspect is really the person who committed the crime. So the investigator have to deal with other factors to really be sure the suspect has committed the crime. So that's the end of the presentation. Thank you so much for your attention. If there is any question, I will be happy to answer it.
Thank you, Chimimana. We can allow one question to be asked, if any. Any question, please? About this presentation. In the audience, no question?
Yes, thank you for the presentation and this case report.
Yep.
How often are you called to the scene to get such samples for DNA analysis? And what has been your experience in terms of contamination of the scene or collection of the material
Yeah.
and also in the use of what you discover by the legal system? Thank you very much.
Yeah, it's interesting you should ask that question. So in DNA analysis, contamination is really an issue because sometimes you get, when you are collecting your DNA samples from the crime scene, you can collect an amount of DNA which is not enough to give a clear profile, and this is really an issue. Or sometimes you get degraded DNA, which normally doesn't give you a clear profile based on while you're doing your interpretation of results. So really, it's lucky when you collect your samples and after analysis you gain a clear profile, but when it happens where you get an inconclusive profile or a partial profile, this is really something that we have to deal with. Sometimes we have to go back and correct your DNA samples, or you should really report your partial profile as it is, because if for instance you corrected your samples from the outside, you cannot go back and correct the sample again. So it's an issue, you deal with it, but it's not easy. So I have to tell you that for the DNA analysis, this is really one of the big drawbacks of it. But as I said, there is other factors to consider to help catch the suspect. You consider other factors in cases you cannot gain a clear profile. Yeah.
Thank you very much. Before we proceed, we can take one more question, and then we proceed to the next presenter. The other person, your question at the end of the presentation. Thank you. Oh, good.
So it is not like a question, but it's like a supporting idea from the question he was asked to respond. You said about contamination and the issue of getting to crime scene. Usually in Rwanda Forensic Laboratory, as he was talking about, we get samples from when they used to call us for go to the scene and take samples there, and we go with our materials. We took sample as well as possible. Just in case of contamination, usually I think we don't get some cases of contamination there, while meanwhile as if we miss or we get negative research according to our contamination. When the investigators bring samples to the lab, while you get something going wrong, we recommend them also to go back to the crime scene where it is possible to get samples also. I think it is like a supplement to the response he used to provide. Thank you.
Thank you.
Thank you very much.
I think there is another guy there.
Yes, we'll keep the question after the presentation, the
Okay.
whole presentation. So our next presenter is Mutijima, and he'll be talking about paternity identification from an aborted fetus. Thank you.
Thank you. My name is Mutijima Fabrice. I'm a professional internee at Rwanda Forensic Laboratory, Biology Division DNA Unit. I'm the one who did this presentation and has been supervised by Dr. Carolina Oanege, Biology Division Manager. This presentation is subdivided into 5 parts. The first one is introduction and background. The second one is objectives, which will be followed by methodology, results, and discussion, and the last part is conclusion. There is an article that has been published in the New Times in 2020 saying that over 78,000 babies born to teen mothers in 4 years. MIJPROF reports the underage pregnancy is ranging between 17,000 and 23,000 each year since 2016. So this case is causing a lot of problems to the teenagers, including the social life disturbance, their mental health, and the financial problems. So some of them feels like they are not able to handle those problems and or to raise the child that will be the result from that rape. And they choose to abort the fetus, which the Rwandan law permits for the defiled or the raped girls. So in those cases, once they abort the fetus, the case is not closed. Instead, it is going to go in the court. So that is where, and because of the heavy punishments on the suspects, so they choose sometimes to deny the paternity. Then that is where the forensic scientists came in place to give justice to the victims. So the forensic scientists, to give justice to the victims, they use the common technique of the short tandem repeats that I will be abbreviating as STRS. Short tandem repeats are the short repeated DNA sequence. Normally they make 3% of the human genome. They are normally localized in the non-coding region of the DNA. You can see in the promoter and also in the introns. The reason we use the short tandem repeats is that these parts of the DNA is highly variable between individuals. For example, you can see on this individual one in the promoter we have like 3 repeats, but on this one we have 2. In the introns, we have 6 repeats, but here we have 3, which shows that there is a high variability in the short tandem repeats. So we use this technique to identify which one was the father from that fetus. Okay. On here we have a case study. A case study was of a man who was alleged to defile his daughter and impregnated her. So as a background, we all know that the fetus is a result of continuous mitosis from the zygote. The zygote and the fetus all have 46 chromosomes, as you can see, but the zygote is a result of 23 chromosomes from the woman and 23 from the man. So from this 46 of the fetus, we can look for the 23 chromosomes of the man. So that is what I said. From the fetus DNA, forensic scientists can identify the father and the mother of the fetus. The main objective of our experiment is to determine if the alleged father is the real father or the biological father of the fetus or not. So this is the materials and methods. From the fetus, we take samples. It is a sample correction with a cotton swab. So we take blood from the fetus on the red muscle, or this one, and from the victim and the suspect, we take the buccal swab with also a cotton swab. Then we do the DNA extraction from the cotton swab. We use the heat and the swab solution. So the DNA from this cotton, these two cottons, will be solubilized in this swab solution. Later, we go with STR amplification on PCR. So on this one, we are going to amplify the short tandem repeats. Of course, it will be for 3, for the fetus, for the victim, and for the suspect. After amplifying the short tandem repeats, then we go on the genetic analyzer and we do the capillary electrophoresis. The capillary electrophoresis will give us the results in form of peaks. These are it is just a sampling here. This is the DNA of the suspect, the DNA of the fetus, and the DNA of the victim. Then we compare these 3 DNA profiles. As I said, the result from here comes into a form of electrophoregram. Then to summarize this and to make it easier, we put it in the table. Like for example, this is the DNA of the alleged father, the DNA of the fetus, the fetus mother, and the DNA of the aborted fetus. These are the DNA STR system. These are the markers for those arrays. So if we're checking if they are matching, for example, you can see that on the aborted fetus and alleged father, the fetus has all the arrays, the same number of short tandem on the arrays, on the same arrays with the father, like 14, 14. 16.3, 16.3, 10, 10. So on all of them, if you can check, they are all matching. So the conclusion, after calculating, we found that the alleged father is the real father of the fetus by 99.9, a lot of nines, you can see. So the conclusion is, the DNA forensic is a very powerful way of giving justice to female victims, whether raped, defiled, or rejected by their children fathers. The recommendation is to raise the awareness among people and community local leaders on DNA forensic science contribution on provision of justice in cases involving rape and defilement. Thank you so much for your attention.
Thank you very much, Mutijima. We can welcome a few questions as you still have some few minutes on your presentation.
Yes.
Thank you for your nice presentation, and it was clear. So the question I have is like, when the suspect, there is no suspect, like a teenager or a baby was been raped by an unknown person, is there where you can help? Is there any help you can give us? Like sometimes we have some children who has been raped, but there is no suspect. We don't know anyone who has been raped. One.
Okay. His question is to know if we can, when there is no suspect, if you can know the one who committed the crime. So till now, there is no way, except if you have like a DNA data bank that we can check who's have this same DNA. But if there was a rape and there is no suspect, then I think till now we cannot find a, yeah.
Second question here.
Thank you for a nice presentation. So about paternity findings, you've told that you corrected the sample of the fetus. So I don't get how you get those sample of the fetus.
Thank you. It was on this slide. I said that we take samples from the fetus. As you can see, there is here a cotton swab. After getting the fetus, you can cut and go on the red muscle, and you can.
No, if I can complete, in fact, either the victim is brought to hospital in Kachiru, then we are called directly there, or if it's further from there, usually the doctor making the abortion is the one collecting from red muscle cells those swabs, and the swab are brought to Rwanda Forensic Lab.
Thank you. So I want also to ask about this paternity testing and this of just collecting sample from maybe fetal newborn. As we know, we have started this kind of self-abortion in Rwanda, but it's like a curious question I want to ask you about your experience, if these things have been started being implemented in Rwanda.
You mean the abortion?
No, I want to mean this kind of testing paternity for those aborted fetus.
Yeah.
So, how often do you, like those cases, for people who are requesting for that testing?
What?
How often?
How often?
Because it seems to be new for me, and practicing, I'm a clinician, and I haven't seen this so much often.
I know that there is a lot of cases, but because I'm new to that place, it's better to give the division manager to answer. It requires numbers, I don't know.
Thank you. In fact, from our effort, it's difficult to tell you how many cases we are testing. If the question is how many aborted fetus are we testing compared to the number of abortion realized, we can't tell you, because as I was saying, most of the samples are brought to us from hospitals. So all that part about sample collection is handled by a RIB. So we analyze the swab we receive. But what I can say is that that number is increasing every day. So now, especially in this period when we had many teenagers pregnant and they wanted to go back to school, and they are allowed now to get abortion, we are receiving an increasing number of fetus.
Thank you very much. We can proceed with the next presentation. For people who have still questions, we have to write them down to be asked at the end of the presentation. So our next presenter is Rahama. He'll be talking about, it's also a case study. He'll be talking about the sexual assault by DNA typing technology using PCR-based STR analysis. Thank you very much.
Good afternoon. My name is Rugama Samson. I'm from Rwanda Forensic Laboratory. Before I start my presentation, I would like also to talk about the previous question you asked Mr. Shimimana about attending crime scene and sample contamination. So for forensic analysts, we don't normally attend the crime scene. They are attended by people, investigators. We are being called for special cases sometimes. So for the sample contamination, we normally see those samples, most of them, some of them, they are contaminated. And you find that those contaminations, they are justifiable. For example, if it is a murder case, you have found the blood stain on the shirt. Actually, this shirt is from the victim and the blood is from the suspect, let's say. So after that, after DNA profiling, you will get a DNA mixture of two persons, the suspect and the victim, but this contamination is justifiable. And with your reference, you can determine where each and every marker or analysis is coming from. So straight to my presentation, it's about DNA testing. Actually, my interest in this presentation is to show the role of forensic laboratory, the role of forensic scientists to assist criminal justice system. So the contents here, it's the background, objectives, methodology, results, and the conclusion. Then on my background of this presentation, actually I'm going to present about the case that took place previous year, last year, 2020. I have had someone here asking how you can test the DNA without suspect. It's about what I'm going to present. So it took place in Rusizi, western part of Rwanda. A lady of 36 years old was killed and thrown in the bush. And then the RIB people, investigators, they collected vaginal swab. They collected vaginal swab and they submitted to Rwanda Forensic Laboratory. Then 1 week later, another incident happened. A lady of 43 years also were killed in the same manner and in the same place. The RIB people attending the crime scene, they also collected the vaginal swab and submitted to Rwanda Forensic Laboratory. So we tested those two samples from two different victims, and we have found that there's the presence of semen through our preliminary and confirmatory testing, through our stain analysis, the first procedure in the DNA testing. So after providing our report to investigators, they said that currently we don't have suspect. So what they did, they told us that you prepare as much equipment as possible. We are going to sample the whole village. So I went there with my colleague. We prepared the sampling room. And by that time, they have developed a suspect list of 32 individuals. We collected the sample. We came up with 32 individuals, and they came to analyze in the forensic laboratory. So the objectives we had for this time is take the samples from all those 32 suspects and do DNA analysis to see whether there is a DNA of a suspect in those two casework samples we had previously, those two samples that were taken or no two victims. So how we did it? Through our materials and methods. First of all, as I told you, we took buccal swab for the suspects, that is the sample used, and also we used the vaginal swab previously collected by RIB investigators. We did sample extraction, we did quantification, we did amplification, and we analyzed our sample with GeneMapper IDX, with genetic analyzer in the presence of GeneMapper IDX software. This is our results. The DNA profiles we get from each and every sample. The samples from the crime scene samples, the vaginal swabs, and the samples from the reference sample, actually the suspects. So the first electrophoregram here you see is for the first victim, for the first vaginal swab. Even the second one, there's just a continuation. And we have found that it is a DNA mixture. As someone said that there might be a contamination. That one is, you cannot call it a contamination. It's just a DNA of two people and can be justified. You can retrieve where this sample came from. The third profile or electrophoregram is for the second victim. Even for the first is for the second victim. And then the fifth profile is from the reference sample, which is the suspect. And you had the 32 suspects. But in my presentation, I would like to show you just only one suspect that matched both the two victims. This is the suspect that matched the two victims. This is the first electrophoregram and the second electrophoregram. So anyway, in our results, as you can see in this table, the first column is the suspect, the second column is victim number 1, and the third column is victim number 2. If we pass through these alleles, these DNA markers, you can see the first one you have 14 and 15. Then for the victim number 1, we also have 14 and 15 plus 17. So this one is a DNA mixture of the suspect and the unknown female. I call it unknown female because by that time you had no reference sample from the victim. I know it is from the victim, but I cannot say it is a victim because I didn't had currently I didn't have the reference sample from the victim. So for the suspect, for the victim number 2, sorry if I go back to victim number 1, it was matching. It was matching. It was consistent. It was consistent. I use the word consistent because some of the profiles were missing. Not all of the profiles, not all of the arrays, not all of the loci were there. So I use the word consistent. Those arrays, those DNA markers that were present, most of them were matching, and I use the word consistent. Then for victim number 2, however much all the arrays were present, but some of them were matching to the suspect. So I can say that they are matching for, they are minor, the suspect is minor in this profile. So that's what I've been talking about for victim number 1 and victim number 2. Then coming to our conclusion, we have said that this suspect was matching victim number 1. It was consistent as you pass through the profile. Most of the arrays were matching to the victim, and then for the victim number 2, some of the arrays were matching the suspect, and we have excluded this. But the reason as to why I said that this first suspect were matching all the victim samples, we have done Y analysis for sample number 2. I didn't mention it here, I didn't present it here, but having failed to the sample number 2, we proceeded with the Y analysis, and this the profile from victim number 2 and the suspect were perfect matching. So in my conclusion, biological evidence, they play a role in the judicial system as the good source of DNA. And in this case, the source of DNA was semen stain and buccal swab, from which one suspect was proved to be the culprit of both two victims. Thank you very much. So if you have any question, I'm ready to respond. Thank you.
Yes, thank you very much. We can welcome some few questions, but keeping in mind that if you have a question also for the presenters who have just presented, also your question is welcome. Thank you.
Thank you. My name is Fred Franzima. I have one question to Dr. Janvier. I want to ask, how long does DNA testing take in criminal cases? And how long does DNA last at a crime scene? And the question to Dr. Mutijimba also is, can DNA be wrong? Also, what mess up with DNA test? Thank you.
Thank you so much for that question. For the time taken for DNA analysis to be completed, it's usually 3 to 4 hours, to get a profile that can be reported. 3 to 4 hours in the lab. Is there any other question not answered? I said it's 3 to 4 hours in the lab. Sorry? At crime scene?
Yes.
Yeah. First of all, the sample has to be collected and then taken to the lab. So I don't understand. Are you asking how long does it take to collect samples from the crime scene?
Yes.
Yeah, it depends on the case. Sometimes if evidence are clear enough, you just collect them immediately. But there are some instances where the samples are hidden, so you have to go through some procedures according to the protocols to correct them. So usually it depends on the case. I cannot tell the precise time taken to correct the sample from the crime scenes. It depends on, it varies from case to the other case.
Okay. So can the DNA evidence be wrong?
Be wrong? I mean, contamination is really the issue. So I'm not sure what you mean by being wrong. So you can get the profiles, I mean, from the person you were not interested in, but still it's a profile, and this is something which is justifiable. So going wrong usually depends on the contamination or having DNA which is degraded, where you get a profile which is not complete or a full profile. So going wrong, I'm not sure what you mean, but really you can say the DNA has gone wrong when you are not getting the person you were interested in or the right person. But from the laboratory perspective, that's what I can say.
I have had some cases like where saliva, blood, all those evidence match, but some people claim that DNA can be wrong. So I'm not scientific. I'm not in a science thing. So that's why I'm asking if the DNA scientifically can be wrong.
No.
Thank you.
No, from the laboratory perspective, DNA can never be wrong. You get a profile. Yeah, whether it's the person interested in or not, but still you get a profile. So which has to be backed up by other evidences from the crime scene or police investigators to help catch the suspect.
Maybe I can help my friend. Yes, DNA profile can be wrong or can be of no use. For example, during my studies, I had a case where one family was having a family dispute, and then the people, the neighbors of that family, they took that advantage. Then one day when the man was not around, they came to intervene. They came to their neighbors in that family. Then they took the knife that was used by the wife. So they went back, and in the way, the man, when they were going back home, they used that knife to kill that man. And they thrown that knife nearby the body, nearby the crime scene. Actually, the body itself is a crime scene. So when the investigation started, they found that the knife, there was the DNA of the wife. There was DNA of that wife, of his wife. And if all of us, we know our wives, they are the ones using knife in the chicken, preparing our food and something. So they used that DNA to make the wife the culprit. But with time, the wife doesn't agree that I'm the one who did it. So she looked for a lawyer, and then after like 5 years, they started the case. They started the case, and they went back to the crime scene, and they found their handkerchief, if you know the handkerchief. And then they went back for laboratory testing, and then they found that handkerchief containing the DNA of the suspect. And from there, the wife was exonerated. So if that was a good example where DNA can be wrong. I don't know if there is another question that they asked Janvier, if I can give also input. The previous question, you asked where the time the sample can remain in the crime scene. Is it? I don't remember even what you asked. If I remember, you asked if how long the sample can remain in the crime scene, but it depends on the situation. It depends on the condition, and also it depends on the amount of deposit. For example, if we take a fingerprint, and all of us will know the fingerprint to be deposited, you have to use this sebaceous glands, the secrets from the sebaceous glands. So it depends on the conditions. For example, if I touch on this table and then it is not it is an open area, then after lunch we may have rain and it washes away that DNA. So it depends on the time when you are seen. Thank you very much.
I want to add something on what my colleague said. You said, can DNA be long? That was the question. On my side, I can say no. But the problem is the investigation. No matter from the theory, even from the practice, we know that the DNA is unique, apart from the identical twins. Then, if my DNA is found at the scene of crime, the problem is not my DNA. The problem is how that DNA comes on that area. Normally, based on my colleague's side, the problem is not the DNA, but the problem is the investigation. During the investigation, you have to tackle different things. The modus operandi. For example, we say, let us take an example of sexual assault. When you find, for example, the semen in the vagina of the victim. In a forensic investigation, we don't say these people raped that victim. We said the DNA in the vagina from the suspect are the same as the DNA from the DNA from the victim is the same as the DNA from the suspect. In that case, it's up to the investigators to ask the victim how comes that the DNA from the suspects is on the scene of crime. That the DNA is not long, but the problem is the investigation. If you investigate bad, then you can mislead the investigation, and also you can interpret, you can badly interpret the results. But the DNA is unique apart from the identical twins. Maybe that's what I can say on that. Thank you.
So thank you very much for all the presenters and the questions. So as we wind up with the morning session, it's time to have our lunch. We'll be having like an hour-long lunch, and then after now we'll be back here, the same place. Bon appetit. Yes, the place is safe. You can leave your computers, we'll be back, no problem for for your belongings.
time, I want us to start our afternoon sessions with the first presentations under this session that will be given by Mr. Fred Kagame, and the title is Forensic Identification of Unknown Dead Bodies Field Practice. So, Fred, you're welcome. You have 10 minutes presentation and 5 minutes question and answers. Thank you.
Thank you so much, Dr. Herbert. As you said, I'm by name of Fred Kagame. So I was supposed to be with Nivis Emmanuel, but he's not around due to other duties. So it's not easy to speak, to be a first speaker afternoon, because while eating, it was like food moving upwards instead of downwards. So, but I'm very honored to be here again. I have a bachelor's degree in forensic science, and I'm a crimes investigator. I also have master's degree candidate in rigorous, specifically international criminal law. So it's an honor for me to be here because even international criminal law originated from German, Nuremberg Tribunal, and then later to Rwanda, International Criminal Court for Rwanda. So here we have people from those parts of the world. So, but now I'm not going to discuss with you about legal laws and articles, but about forensic science. Specifically about forensic identification of unknown dead bodies, field practice. So we are going to see introduction, aim of presentation, identification techniques, and some techniques that we do use here in Rwanda while identifying unknown dead bodies. We are going also to see a case and some challenges and some alternatives, and then to conclusion. So we are going to be together. In short, I will not go in detail, but I will give you time for asking questions. So in our daily life as investigators and some police officers who used to have the same things of crimes investigation and dead bodies identification, we face with this challenge of whereby people go at the scene or in some places and get or meet with the challenge of someone who died without any document, either passport, national ID, or any other document which you may use to identify him or her. And through those challenges of facing those kinds, there are some techniques and methods developed or used, adopted by forensic scientists, especially crime investigators and other forensic investigators in general. So the aim of presentation is to give you or share with you those techniques and then see some experiences in the domain, and we will see some challenges as well and recommendation. So some of the identification techniques, more as technology appears and as we develop in terms of technology, in terms of science, there are some techniques developed, such as DNA. When you don't have identity of a person, maybe document or any other official document, you may use DNA as a mode of, as a technique of identifying the individual. You may also estimate the age of someone, physical appearance. You can determine the age of an individual. So you can also see gender, can guide you in identification. You can also use skin color, whether black or white or any other. There are also anthropometry. There is dental examination, the teeth. There is DNA identification. I have talked about this. But I'm going to go specifically on fingerprint identification technique as a new technique which appears, and we are applying it here in Rwanda, whereby we have a fingerprint kit. It's here. This is a kit. This is one bag composed of all those other things. So we use it at the field or even forensic laboratory for identifying individuals who are not known. So while identifying individuals, we have procedures. This is an application we use. So you can know whether we do check by using 4 different, it has 4 different tabs. You may choose whether it's a Rwandan or a foreigner or a refugee or a migrant. So you can, here is left thumb and right thumb. So by using those 2 and then facial recognition, we can identify whether this person is a Rwandan or a foreigner. Then we have that challenge of, as I've mentioned, there are some challenges such as not having a database. We don't have DNA database. We don't have forensic fingerprint database. But we go to National Identification Agency. They have all fingerprints of all people, the migrants. But they have in their database, they don't have under 18 years. And even some illegal migrants, they don't have them. So that is also another challenge. This is a case whereby 180-meter young man was found without any other official document. Unfortunately, we at the first place at the scene of crime, he was in a small room, and at the first time we thought that he's a white or someone from Arab, because he used some medicines which destroy the melanin skin color. So he was looking like white, and we after not having ID or any other document, we tried to call neighbors to see whether someone can know him, but no one. He was about 23 years. And after taking or using this fingerprint technique, we knew him. He was a Rwandan, and he was in nearby village. But because after doing autopsy and further examination, they have seen that he was dead due to drug overdose. But no one who would know that if we couldn't have this technique of fingerprint taking machine. So we go at the field or even at lab, and we do take fingerprints of a known dead body, and then we go for DNA, for NIDA, to identify or to recognize individual. So we have some challenges, as I have mentioned. We have one is there are some cases where we go at the field and we get some people who are already decomposed. The skin is no longer there. The skin of fingerprint ledges, the froze. So that used to be a challenge, and sometimes young people, children, we don't have database. Depending on the case, fingerprints may be there, but he has no ID. He has nothing which you may use to identify him. So that is a challenge. But some alternatives, as I've mentioned, they are there, like DNA. You can use DNA to identify that individual. So you can ask yourself why. Why are we why do we need to know individual? As I have mentioned, forensic science, there might be some people here who don't know what forensic is. It's the application of scientific techniques in administration of justice. So you cannot provide justice of unknown. You need to first identify the individual, then later you come to know him. So as conclusion, investigating the cause, the manner, and even mechanism of death is paramount important. Identifying dead body, paramount for identifying dead body so that relative may get moral emotion, moral affections, and effective justice. So there is it's very important for the family and even for the justice to identify the individual. Thank you so much. As a recommendation, it is necessary and it is important to enhance and put more effort in improving this identification of a known dead body, either in region or particularly in Rwanda. Thank you so much.
Thank you so much for the good presentation and very concise and time. If there are any questions, I'll take one or two clarifications. Yes?
Thank you, Kagame, for your nice presentation. I would like to know whether using this fingerprint taking machine, are there some cases of false acceptance or a false matching? Did you face such cases just while trying to identify some of the dead bodies? And another thing is regarding to the recommendation. As you did most of your researches and studies regarding these dead bodies identifications, do you think is it necessary to establish, because in some cases for decomposing dead bodies, we see that they are, in some cases they are decomposing and you can't find the fingerprints. Do you think is it necessary to establish a kind of national biometric center whereby we can be having all the biometric data? Thank you.
Thank you so much for nice questions. I can start with the second. You said, is it necessary? Of course, it's necessary. Sorry, I did not mention it, maybe. But there is a need of having that center of biometrics, as well as establishing fingerprint and DNA data bank, because we don't have them already here. But other countries, they do have it. So your first question is, yeah, first matching. So it can happen, but not, it may happen, but not, we have never met with, but rather we have a challenge of missing some people in database while they are not unknown. But first matching is not usual because, as all of us we know, fingerprint is unique to each and every person at the universe. You cannot, even if it can be your twin, you cannot share the same fingerprint. So it might happen if decomposed, you get small part, but if it doesn't match, you ignore. You may get small part sharing to another one, but if someone is living somewhere and you're getting the fingerprints, already you have a cadaver, you have a dead person. So if it's matching to someone who is living somewhere, it means you're missing something in information. Better you ignore. Thank you so much.
Yes, thank you so much. I hope that's clear. Now, without further delay, I would like to call upon the next presenter, John Karimera, who will be presenting about the role of microbiology in forensic sciences.
Good afternoon, all of you. I'm very privileged to be here presenting the role of microbiology in forensic service. I'm called Karemera John from Rwanda Forensic Laboratory. So it was found that pathogens and their toxins can be converted to bioweapon and used to commit bioterrorism and biocrime. So in simple terms, bioterrorism, it is where we can use biological agents like bacteria, fungi, virus to commit crimes or bioterrorism. It is in this regard that this new field of microbiology has been created, which was focused in characterization of evidence from a bioterrorism act or biocrime hoax or an inadvertent release. Then how this forensic microbiology came into existence. These are the steps that led to the foundation of this new field of forensic science, whereby following the trend of different years, there was existence of outbreak of pandemic, which found out that it was due to biocrime or it was intended. Starting from (430 to 436, not 26), there was outbreak of Paraguay. This was mainly purposely done by the group of people from Sparts in Greek, where they used to spread this kind of contagious diseases caused by Yersinia pestis, infecting their counterpart, which left them to win the war, which was called Peloponnesian War. And again in the 14th centuries, there was also another incident which was called the Plague Death in Europe, whereby there was also the same outbreak where many people were died, especially in Asian parts of the continent, in China and India, leading many people living their lives. Again, during the First World War, there was outbreak of anthrax, which was found out that it was due to German military people, which they used the anthrax bacillus to destroy animals and plants. Again, 1932, there was another outbreak of the same contagious infection affecting about 2 million people and above, especially in China. Again, 1940s, there was the Chinese people, they were using the same biological agent which was found in ceramic containers, and then they were using it to kill many people in the region of Manchuria, which is the part of northern part of China. In 1979, there was also an outbreak whereby the Union of Soviet, they again used the anthrax bacillus, and many people were infected, and 68 people were dead. Again, 1984, there was outbreak of Salmonella infection. In other words, it was spread of diarrhea caused by Salmonella, whereby 751 people were infected, and 45 of them were hospitalized in the Dallas, in the region of Oregon. Again, 1998, there was a physician doctor who was suffering from hepatitis C virus, and he used his blood to administer to different patients that he was receiving. Those were they were the patients that were supposed to attend the surgery, and then he could mix his positive blood with hepatitis C with those chemicals that could relieve pain during surgery, and then inject them. And at the end, all these people were found hepatitis C virus positive. Again, in 2012 to 2013, there was recurring and emergence of anthrax bacilli. I mean, they used the anthrax bacilli by the heroin users. Those who are drug takers, they could mix this biological agent in the heroin, and then there was outbreak, and then it started spreading from Scotland, expanded to England, Germany, Denmark, and finally in Britain, leaving 62 cases and 27 people were died. So because of this outbreak recurring and emerging of these diseases with many acts of bioterrorism and biocrime, the FBI decided to set up two groups, that is scientific working group of microbiome genetics and forensics in order to address such a problem, and that's how forensic microbiology came into existence. And then after existence, how this new field of forensic microbiology assisted in the field of forensic science. So these are the roles that have been played by forensic scientists in order to address the challenge that have been found in forensic field. One, there is bioterrorism. Bioterrorism, it is whereby we intend to use biological agents to kill the group of animals or to destroy plantation with a purpose, indirect purpose of maybe causing people to starve due to political reasons. Again, there was also they also tried to identify and detect person-to-person infections like HIV/AIDS, which can be spread from one person to another with purpose or with planned intention. Then there was also, there is sexual assault and the child abuse. This also the role that has been, that is the issue that also has been addressed by new field of forensic microbiology, whereby, you know, sexual assault, it is one case, but also causing the infection, it is another case. So once there is defilement, that is one case, but we can also, again, come across to the suspect and then identify if he has been with any STDs like HIV/AIDS, hepatitis, gonorrhea, Neisseria gonorrhea, and so many other STDs. Again, there has been the problem of malpractice judicial complaint. For example, like organ transportation. This can be exemplified maybe by where can a medical doctor can organ transplant a new organ with maybe affected disease like HIV or hepatitis to a healthy person who doesn't have such an infection. So due to these malpractices, this new field of forensic microbiology has been needed in order to address such challenges. Again, there is what we call violent deaths. This can be exemplified by drowning. There are some new molecular tools that can be used in molecular microbiology, whereby one is able to identify the dead body that has been found in water. Either the person has been killed and then thrown in water bodies, or the person has been fallen in water and then was killed by water. So we can use the techniques in microbiology to confirm that incident. Again, forensic microbiologists can be also able to manage the crime scene management. So we can work with other fields of forensic sciences to investigate how the crime scene or the incident that has been happening in the crime scene. And then we can also use forensic microbiology to determine the timing of death. That is, after the person has died, there is what we call microbiological changes. That implies that we can work with legal medicine to determine the timing of death. So, and then that is in general application of forensic microbiology. And then forensic microbiology in Rwanda, or Rwanda Forensic Laboratory in particular. So reference made to the law, to this law, establishing Rwanda Forensic Laboratory, determining its mission, organization, and functioning, especially its Article 6 of providing its clients with services of conducting scientific analysis of evidence for judicial purposes and services requested by individuals or other institutions, organization, whether inside or outside the country. So it is in this regard that also found that microbiology is also needed in order to address the problem of law enforcement by understanding what may occur during biocrime and biothreat event, by differentiating the natural outbreak and intentional release biocrime or by terror that attacks during investigation. Also by identifying the scientific challenges that should be made to improve the capability of forensic microbiology to provide evidence of sufficient quality by supporting legal proceedings. And then this is now forensic microbiology in our field. This is a new field, and then these are the, this is phase 1. Now we are in phase 1. That's what we can do now. These are the techniques now, right now we can do, and we have the consumables and all the capacity to do it, especially classic microbiology, which involves culture, gram staining, microscopy, biochemical tests, and serological tests. Using these techniques, we are able to address the problem of food poisoning or intoxication, autopsy microbiology, whereby we work together with legal medicine in the case of we suspect sepsis in the blood or any other incident that has happened, like a person has been died after taking some food, then we can work together in order to give tangible results.
2 minutes.
And then there is sexual assault and outbreak investigation. Then this is the phase 2 we are planning. We are planning to have molecular techniques and biotyping and serotyping. So after having it, we shall be able to carry out microbial detection, crime scene cases, and malpractices, and postmortem changes. So these are the challenges. It is a new field, and then we lack awareness. There is also the chain of custody to attend the crime scene. We don't have, we still have limited resources. Again, we don't have technically based training institution that can assist us to gain more skills. And then to address this, we need to raise awareness. We need more training. We need more to purchase more tools in order to carry out analysis. So basing on what I have been explaining, it is found out that forensic microbiology is needed in order to address such challenges. Thank you.
Thank you so much for the good presentation. If there are any questions, I will take them after the at the end of the session, and I want us to proceed to the next presentation with the title "Serial Number Restoration on Second-Hand Equipment." This will be presented by Dr. Chingabigwi. Yeah, the microphone. Thank you.
My name is Emmanuel Nshingabigwi. I'm Physical Evidence Division Manager in charge of ballistic and tool marks, question document and fingerprint, as well as digital forensic. And this presentation falls under ballistic and tool marks. We will be talking about the serial number restoration. As an introduction, we can say that serial numbers are used as unique identification marks for a range of items, such as automobile engine blocks, and we mean by that engine or chassis numbers, electronic equipment, motorcycles, and so on. But it's also known that they can be erased by offenders involved in criminal activities such as theft or illegal use of stolen items, so that the origin and the ownership cannot be traced. But we know that some methods are available to restore the erased serial number using predominantly the chemical etching. We go through some definitions. Serial number, it's a unique number typically applied to an object by the manufacturer, and serial number restoration is the practice of restoring an obliterated or erased serial number by using scientific methods. And the restoration of markings or serial numbers, it's an important forensic discipline that includes the science and the technology of materials. And it deals with some aspects of solid-state physics, chemistry, metallurgy, and engineering, but I will keep it simple. These are the types of serial number application methods. Mainly, we will be talking about stampings and laser etching. So this is an example of a dot matrix. We can see that it's a dot matrix engraved serial number, which is fairly shallow and are made by a succession of dots. This is laser engraving. So they are also shallow and they have a band-like appearance, as you can see on the picture. The stamped serial numbers, it's the common method used. And we maybe that the theory says that when a serial number is stamped in metal, plastic deformation of that metal occurs. I spare you, plastic deformation means permanent deformation. And after the force causing the deformation is removed, the impression remains. So we can see over there. Maybe I can skip this. So obliteration is when a serial number is erased. They are ground down beyond the lowest point of the original stamping. And by removing the serial number, criminals hope that the object cannot be identified as having been stolen. Let's just, these are some serial number, some chemistry. And for visualizing restorations, one take into consideration in optics specular reflection, whereby the reflection is done on a smooth surface. And we will see, it will be the reason why we will see that we have to polish the obliterated serial number. So this, as you can see, this is a smooth specular reflection on a smooth surface, and this is diffuse reflection on a rough surface, and this cannot give us information. Serial number formula lists. Sorry. So we have some ferric chloride, some Fry reagent. They are a mixture of acid which help in the restoration of erased serial numbers. So here we give just a picture of an obliterated or erased serial number. So it has, as we can see, it has a surface that has been scratched so that the number is no longer recognizable. So what we apply, the first step in the process of restoring the serial number is to polish by using sandpaper. Polishing the surface will help in visualizing the serial number. So then the second step is the acid etching. So the acid reacts with the metal, and produces hydrogen gas bubbles. Then the result of the acid etching is a restored serial number, and we can say that the dark appearance of the numbers is the result of the diffuse reflection. And so documentation, one has to take a quick picture or write down the restored serial number. Here we give just a case study. An ATV, ATV stands for all-terrain vehicle, was suspected of having been stolen from a local leadership. When police attempted to read the vehicle identification number, it was observed that it had been erased. So the number in question was located on the engine. The surface with the erased number was located on the top of the engine. Then this area, this is the area on top of the engine where the VIN numbers were stamped. So the first step, of course, of the restoration process will be to sand it smooth. After the surface was sanded, acidic ferric chloride was applied to the engine block, and then the vehicle identification number was restored to H31OE and so on. So in conclusion, this, as I said, it's a project. Rwanda Forensic Laboratory, through ballistic and tool marks units, is seeking to provide serial number restoration either on second-hand items, on vehicles, on firearms, using chemical and physical restoration techniques whereby the numbers can be made readable again. So we have potential clients, Rwanda Revenue Authority, judicial systems, Rwanda Investigation Bureau, prosecution, court, even private. And in that regard, we will be able to authenticate the questioned firearms, vehicles, and various equipment. We will also be able to provide forensic expertise report and give testimony to the court. At the end of this project, the facility that restores serial numbers should be available to the public for the fair administration of justice. And here I give some resources. Precision forensic test, which is a private communication. There is also serial number restoration of second-hand equipment, which is a ballistic and tool mark unit project 2020. And there is a paper on the development of new reagent for restoration of erased numbers. But before closing, I can give an estimated budget. The requirements are just a hangar. We need also some reagents. We need 2 or 3 forensic experts and a mechanic to help visualizing the serial numbers. And it amounts to about 200,000 euros. Thank you for your attention.
Thank you so much for the good presentation. I think we have some few minutes. I will take one question, short and concise, if there is any. If not, thank you so much. We'll proceed to the next presentation. Of course, there will be a time after the session, or even during break, where you can, ask your questions to the presenters one-on-one. So, I would like to call upon the next presenter. The next presentation is evaluating the challenges of chain of custody of biological evidence in solving crimes in Rwanda. It was supposed to be presented by Sema and Anastas, but he delegated Janvier to do the presentation. So Janvier, you have again 10 minutes and 5 minutes in case there's any questions. Thank you.
Thank you very much. Thank you very much. I'm here also once again at Juxenye Janvier. I presented about thromboembolism. By the time I'm going to present about evaluation of chain of custody while doing with biological evidence solving crimes in Rwanda. This is a research that have been conducted in 2016 by a forensic scientist. By now, it's working in Rwanda Investigation Bureau, and as he's not here by today, he used to say that I should be here for him, and I hope it's gonna be fine. We can ask ourselves, what is biological evidence in the case of solving crimes? Several presentations this morning have been talked about DNA and fingerprint. Here is a kind of source of biological evidence. We can see blood, saliva, semen, teeth, bones. And the problem we are dealing with is which kind of challenges that these investigators meet first during collecting evidence, processing evidence, just to contribute to criminal justice system. We think about DNA. Every time we talk about biological evidence, we talk about DNA. Now we're going to have a concept of chain of custody. We talk about the whole abstract of the study, the problem statement, the material method, the research presentation, and the conclusion he made during this study. The main objectives of the study was to evaluate and assess the challenge that faced by investigators at crime scene while conducting biological evidence that should serve to solve this crime, to suggest sustainable measures that should overcome these challenges they used to face. By definition, a chain of custody is a process that count on traceability of this evidence we are dealing with from the crime scene up the time it serves in the court. And by the history, the National Institute of Justice used to define chain of custody as a process of maintaining and documenting the history of evidence, and which consists of the name of initial of the corrector or person who used to go to the crime scene, who used to touch the evidence, the correction, and everything that must be recorded and documented around the envelope and the packaging of that kind of biological evidence used to be collected on crime scene. Biological evidence is any body fluid originated from living organisms, and it can be helpful in serving as source of DNA that should be used to connect or to link the suspect with the crime scene, and the DNA extracted from that sample will be useful to detect either or to exonerate or to deal with the one who used to the crime being at that crime scene. The sample size during this study was 30 judicial police officers, whereby the questionnaires have been set to during collection of this study. So the challenge that during this research, the main challenge first, while collecting this biological evidence regarding the respondent, most of them said that it was insufficiency of appropriate materials and equipment. Remember, it was in 2016, but now we are in 2021. Then other 20% of respondents said that improper temporary storage the standard operating procedures depending on the growth of technology. As we said, the change of time, the change of the storage, the rest of storage time while doing this, it was a problem. Then we have to predict, carry, depending on the time, standard operating procedures. To improve the manner used to transport biological evidence from one place to another place. In crime investigation, biological evidence is useful, and if used to transport it as the manner you want, the manner it is not properly, you can make a contamination, or you can just try something that should impair the good, and you can fail in your investigation, while you should use the proper one so that you can achieve your duty as well as possible. Regarding the material and method, we use questionnaires. As I said, the standard population, I said that the whole population considered the judicial police officers in Rwanda, but the population, as I said, sample size was 30 judicial police officers. And to correct data, as I said, we use questionnaires, while we use the management of data is that software called statistical analysis, that software called the package of social sciences, and that version. This is presentation of the results. As I said in the abstract, most of our respondents said that the main problem was, you can see 23.3% is the great percentage that said about insufficiency of proper materials, so that should be helpful to conduct, to do the work as well as possible. That was the challenge. And insufficiency of experience, it's like 13.3. Lack of specific DNA law, and that time they were not a specific DNA law, whereby it was also a challenge. And now they said improper temporary storage. You see, previously at the crime scene, nowadays they're having like a small fridges in that car, the moving car, whereby you can have that storage, whereby some facilitation that is applied to conduct investigation, to take sample as well as possible yearly. And this storage can be, by the time it is helpful and engage in achieving. This one is about the recommendation measurement to overcome these challenges we made, whereby a big percentage of respondents said about the proper, to prepare periodically SOPs, so that we can, the management of this case and management of the procedures will be followed up, so that it will be helpful to conduct this investigation and overcome those challenges. As conclusion, while doing that research, we saw that there were many challenges that have been faced during conducting this biological evidence, and was based off an insufficiency of experience and knowledge of skills of the judicial police officers, as now it is in process conducted by Uganda Investigation Lab staff. And nowadays we are having a forensic scientist in the Uganda Investigation Bureau, where we will see the team called the SOCO, as like crime scene officers. Those people comes in forensic field. We think now there is in experience, there is some of experience by the time. It is no longer as previously. lack of specific DNA law, awareness to Rwandan society on how to manage this biological evidence. You know, even previously, even these people around in Rwanda, they didn't think about what to be managed while dealing with investigation. As long as there is no awareness, as long as you can get evidences authorized. As conclusion, the proper handling of biological evidence from crime scene or unknown person that should be contributing to investigation, whereby you can achieve good and better results from the investigation. Catching up perpetrators, identifying the source of errors while the chain of custody is well done. You should locate where the error have been committed, and that should be detected and corrected. The recommended measurement, just as we saw to overcome this, you have to learn and get experience to handle this biological evidence, and we should teach and mobilize the Rwandan society and people around how to manage biological evidence. Thank you for your kind attention. If there is any problem, question, please, you are welcome.
Yes, thank you so much, Janvier, for the presentation and on time. So we are now 20 minutes behind schedule. I would like, since this is the end of the session, we take a quick break, 10 minutes, and then we come back at 3:30. If you have any questions from this session, please get in touch with the presenter during the break so they can answer your questions. Thank you so much. So please, 10 minutes, 3:30, let's be back. Thank you. with the title Fostering the Training of the Professionals to Treat Trauma and PTSD in Rwanda. Joseph, you have, the time. So the floor is yours. Thank you.
Dr. Hubbard? Dr. Hubbard, someone was saying if you can give me 1 minute off my 15, just for one.
Sure, go ahead.
Okay, so let's stand up quickly. Sorry? With Mukamuson again. So what should we do? So I know it has been so hectic, so if we can do a quick stretch. A quick stretch. Sample. Okay. So any physiotherapist here? Or reflexologist? Okay, so can we, let's follow Fabian. How he does it. Yes. So enough stretching.
Okay, so everybody's doing like that.
Do you have any song? They can sing Mukamuson. Okay. And reach down. Okay, that's it. Thank you very much. So as the Dr. Hubbard said, my name is Joseph Kalisa, and I'm glad to be presenting today here. For the next 15 minutes, I don't know if for some who have been coming back here, remember we talked about PTSD, we talked about trauma. I don't know if maybe people are asking questions, how is it related to forensic medicine, which is the summer school. The idea is you can't do anything in Rwanda without bringing historical context into perspective. And so as the conception of the forensic summer school, we included workshops in terms of psychotraumatology and PTSD, knowing that anywhere there is going to be a relation in terms of how mental health is affected and all. So I work at the Center for Mental Health as the capacity building coordinator, and we do also carry out a number of research. So globally, when you look at, I will be speaking briefly about PTSD or trauma, specifically, let's say trauma. I think everyone knows in Rwanda trauma, right? When you have a trauma, you don't know how it is, maybe, but everyone in Rwanda has become, at least everyone here knows, has some specialization in knowing at least the neighbor who is affected with trauma or someone who has, it's often that communities were going to say trauma. So we wanted to know, in 2018, with Professor Vincent, Professor Leom Tessa, Professor Pusho, and Ingo, they haven't been able to be here, those ones, because of COVID, obviously. We wanted to know, if we are talking about Rwanda, and we know the context that there is a trauma problem, given the history of the 1994 genocide and also the historical conflicts. Do we, how many, how is it in terms of professionals who are trained? And it was from the inspiration from the summer school themselves that we're having here. So we wanted to know how is the situation of trauma treatment? And when you look at it globally, you find that trauma itself is a global problem across countries. For example, when you look at in Rwanda, recently the Rwanda Mental Health Survey that was done, they indicated that about 79.4% out of the 1,000 people that were being asked, at least they had experienced one traumatic event. It could be genocide, it could be an accident, it could be all those that are categorically as traumatizing, or abuse or rape. And the mental health survey also gave us a picture of the different other mental health disorders as a show of how the magnitude of mental health problem is in the country. In those 12% in the general population, they had a major depression. So depression is usually taken from the clinic perspective as a comorbid, like because it's a sister to PTSD or is a friend to PTSD. And the 35 people among genocide survivors had expressed PTSD. I mean, that was called trauma. Then when you look at the prevalences as well, like in, these are figures, and I don't want to go because of time, you can see them. So you can see that all these are pointing out the need for having interveners, people who are going to intervene, who are going to support in caring or in supporting people with mental health difficulties, especially trauma. So the context, the current situation, and this is in the paper, so it was in 2018, this was the current situation. When you look at how many people, we wanted to know how many people do support, how many institutions, how many organizations are into supporting people with trauma. They were in two groups. There were groups of NGOs, non-government organizations, and there were groups of government. So there is a way that the government intervened after the genocide, especially like in 1995, to set up a policy that was governing in trauma treatment and mental health globally. So what we see is the non-government organizations were specifically responding to genocide. If I could give you a picture that I will give later on, is that in 1994, just after genocide, there was no and there were around 3 psychiatric nurses. So a lot of non-government organizations came in after, for example, Handicap International and other NGOs, to intervene into psychosocial and trauma treatment. So there is that category, and there is a category from the government itself setting up institutions. These are now the available services. So you can look at, there are those that are clinical based, and there are those in handling or in supporting people with trauma. And you find that a number of these don't. They have had very short courses, but there hasn't been a full whole-scale training specifically for trauma. You find that a mental health practitioner was trained like in a number, so there's no specialization specifically for trauma. So you find that they are dealing with depression, they are dealing with addictions, they are dealing, so there's a whole range of it. So that limits on how interventions are done. Because the other thing I didn't mention is that in 2012, when the research that was carried out by Dr. Nason, the prevalence that was showed and the prevalence that was shown in 2018, there was no that much of a change. So the question was, why? which brings it that the training is much needed, and see how do interventions being done, that whether they're effective or whether there's something that can be fostered. These are legislatory bodies. I think we don't have to dwell much. But a little bit is, if you look at the service utilization that was mentioned, which is almost 5.3% of people who use mental health services. That's a is an association, and the Association of Rwandan Trauma Counselors. So those were the ones that we saw that were specifically trying to work with professionals. So the scope of the problem of trauma in Rwanda most requires And when we reviewed all the curriculum at the University of Rwanda, we reviewed the curriculum from the IRS Eteruhuka and the curriculum from the university that was closed of Chibungo. Is it Inatech, I guess? You find that there wasn't a specific curriculum that was focusing on trauma treatment. So when I talked with Dr. Hubbard, we were like, there was another presentation, which was how is now the situation in terms of COVID-19 now. So the one with the Laguhan Code. So during the COVID-19, we looked at how is COVID-19 affecting now mental health. You can see that it was a situation that was already worse. So there was existing mental health difficulties in their communities. So how do the situation with COVID, how did it worsen? So we did a very systematic review of the existing literature, but also they reviewed during the COVID, we reviewed some of the research that was being done by the university for the students and the rapid analysis that was done on COVID. So this is the situation before the COVID. I think I mentioned about it. I'm not going to go through it. So most of the things that have been affected much with COVID now has been mental health systems. So every finance, I don't know now, but in any hospital, whether you're working in a hospital, you know what is the priority now. It's COVID, right? So it's treatment, it's measurements. So all resources have focused on on COVID, like the physiological effects and all that. And normally what happens when such things happen is we forget other difficulties or other illnesses that are happening. So that's what has happened with mental health as well. That it has, COVID has shadowed, but it has also brought out a very significant repercussions on people who are experiencing COVID, but also who had mental health difficulties. So healthcare institutions were really mostly devastated. Community-based programs that were supporting people, for example, you know that this with COVID, community programs kind of shut down. So there were no, these organizations were no longer going to the community. You find that students who are going to schools, and schools did a fundamental part in building and bringing a consolidation for people who are having difficulties. Children now became more exposed. Young people who are not attending schools. And healthcare visits, you know that now it was difficult for people to visit you or to go to the hospitals. People in prisons, you know how that you haven't been, people are not allowed to go to the prisons. All those don't brought a so devastating mental health impact. Yeah, so the specific groups that we looked at that were really very much devastated were people with underlying mental health illnesses. For example, those who are being in Indera, Changase, who are receiving treatments from such psychiatric hospitals. They had a very, very devastating effect. Then the other people were people, you know, culturally, once you lose someone, gushingura ikiriyoni is very important. People were not able to go to do that. And that brought a grief. So a group, people who are not able to bury their loved ones, who are not able to right? So it became so much devastating for such a group of people. So given also the culture, because these things also go with culture. So from the mental health perspective, such cultural practices are very important. And if it's not done well, it brings on a long effect of bereavement and a long effect of grief. Other people that were affected were victims of violence. For example, those who are working in Isange One Stop Center or who are working in families. You know that gender-based violence increased in our families because now you're restrained in the same area. So these people are really very much affected. We don't have statistics yet, but when you look at anecdotal data, you can see that there's a high increase in terms of abuse during COVID-19. Then other people that were very affected, I talked about them, children, but elderly persons. So elderly people who didn't have, for example, who didn't have people to take care of themselves, but also they were the most risky. Everyone was like, it kills, especially the elderly persons. So that anxiety that was inflicted into elderly people as the target, or who are most at risk of dying of COVID, became more and more devastated. Other people were people with impairments, for example, people who have disabilities and people who have other special needs. This is still elderly persons. Other people, I talked about the incarcerated persons, people who are in prisons. Even now, there are so many people who are not able to go and visit people in prisons. So that is really devastating. I will end with one quote. I can see Dr. Herbert is up. There's one Indian professor who said recently that we have had, I think this is now another, is it a third wave of COVID? Yeah, this one that is coming, the fourth. And he was prophesizing, which is a bad professor, but that another wave that will come after this COVID is a mental health wave because of the devastations that the impact the COVID is bringing. No one is sure whether tomorrow we are all coming back, because I'm not trying to scare you, but anytime we are not sure, right? So the uncertainties. So, but there is a silver lining that people have also came up resilience and resistant to these conditions. And as you can see, the adaptability that people are coming in with COVID, you change things. When I wrote the email in last night saying come with certificates, I was like, okay, so those changes people are used to, they are not going to fire you on that. So that's it briefly on the two presentations, Dr. Albert.
Yes, thank you, Joseph, for the presentation, and right on time. Any questions for Joseph before he takes his seat? Huh? Good. Then I think then the presentation was really clear. A big hand clap for Joseph. We'll now proceed to our next presentation with the title Resilience Through Trauma Healing Group Support in Rwanda. It will be presented by Ms. Mukama, sorry. And you have 15 minutes. Thank you.
Good afternoon. My name is Mukama Naderite. I'm a clinical psychologist specialist. I used to work with the community members, and what I'm going to present here is at the same time an intervention, but also a research. I'm going to talk about resilience through trauma healing group support. Yeah, I start by defining what is healing, because normally in the mental health, we not use this to heal, but this is a word normally used when we want to make a whole or bodily condition to free from disease, or to restore the health or soundness. That is the definition of healing. But here we are talking about healing in mental health because our society was very wounded by the genocide against Tutsi, but other also causes of wounding event. And societal healing can be understood as a process where individual and the society become health again after an event or series of events of extreme violence that occur within a society context. Here in Rwanda, we talked about genocide, but there is other also event that happened even before the genocide. The exile of some Rwandese, the wars, that also was like a wounding event. And as far as resilience concerned, it can be defined as psychological strength to cope with stress and hardship moments. It is the mental reservoir of strength that people are able to call on the times of need to carry them through without falling apart. Psychological believe that resilient individuals are better able to handle adversity and rebuild their lives after a struggle. As my colleague Joseph said, many ones had at least one moment of traumatic event. But at the same time, even if we see that there is a big number of traumatized people or presenting other mental disease, but there are few if you compare with the traumatic event that happened in this country. And to define the context, there is a society that is wounded, and in this context, people has lost the loved one. There is incomplete mourning because some of people didn't have that chance to bury in a dignity the loved one. There is rape that happened during genocide, but also after genocide, there is that context that there is a labeling and stigmatization. We see that in perpetrators and their descendants because they have that guilty, they are considered as perpetrators even if they are not, for example, for the descendant of the perpetrators. And there is that transferred guilt in our community. There is this context of historical and political violence that happened. There is genocide against the Tutsi, there is wars, there is exile, all that context that caused a wounded society. The society was broken by the genocide. We see that there is communities are broken, there are psychological wounds, but also families. Now, there is a background of mental health and now is considered as public health issue in Rwanda. And considering the statistics from Rwanda Biomedical Center, the survey that they have done in 2018, the depression is 35% in survivor population, while it is 12% in general population. It's a big number. And even before the survey from the Rwanda Biomedical Center, there is a study conducted by Munyandamutsa and all that demonstrates the post-traumatic stress disorder was at 26% and the depression at 22%. And survey from RBC demonstrates also a big number of PTSD among survivors, but in the general population also there is 4% of the population that suffer from this PTSD. There is also a panic disorder that is 27 among survivors of genocide, but also 8% in the general population. There is another research conducted by Hagengimana in widows that demonstrates that panic disorder, it was at 35% in 2005. Now, what we did is to think about what we can do, and we've tried to do what we call a baseline to see how we are going to intervene in the community, because some of the wounding events and the wounds comes from that wounding event are not that, they are not come to the hospital because people didn't consider themselves as some who need the help at the hospital levels. If we see the people who went to the hospital or in a survey they did by the RBC was 4% of people who need to go to the hospital. And during our survey, we see that the whole community is wounded, but we focus our intervention on community members, in unschooling youth, and we have been inspired by that survey we did. And what we did during our intervention is to break the silence, to break the isolation, to construct the stereotypes that was observed during our survey, and provide psychological resources in a group, because we choose to do our intervention in a group. And we tried to have that safe spaces to facilitate the relationship, and to create also this sense of belonging among the group members. In our assessment, we've tried to measure three things: trauma and trust and social tolerance, because all these, we have been see that this trauma, if the trauma is high, the trust is low, and tolerance is low. And these three things that is very key if we want the society that is resilient. We've considered the trauma, people as someone who has experienced a traumatic event. And during our research, we see that it was 400 participants, and these are numbers of participants in our baseline, men and women. And we see that if the trauma goes down, the resilience and the trust goes up, and the tolerance goes up, and that creates a situation where resilience is possible. And the psychological distress, 66% declined to think of suicide, because during our intervention, our survey, we see that people were thinking about suicide. And after the intervention, these ideas of suicide reduced from 15% to 5%. And 50% decrease in people who reported depression, and 35% decrease in post-traumatic, and 25% overall improvement in psychological resilience. We learned that these healing spaces is a strong foundation for resilience process. Healing support group approach proved to be effective to address healing need in Rwanda, because this space, those spaces we create in our society, in our community level, are very helpful for the community, because it tackles a lot of numbers of people. At the same time, it's build ties between people in the community. And the approach we use is narrative approaches and psychodynamics techniques for those who are familiar with the technique of psychology. It's allowed the members of space to open and sharing traumatic experience, particularly for those who are deeply wounded. And it's more feasible in a group where people share a common wounding event. We've created the group, different group according to their suffering. You have some groups for women left during genocide, for youth, for different groups. Sometimes for those who are deeply wounded, they are in what we call homogeneous groups. Healing takes time. It is not a linear process. Individual experience, the need are key to understand the complexity of individual healing and its relation with the universal and the social adaptation, and the intervention accordingly. These protected spaces, where with respect to confidentiality facilitated by experienced professionals, seems to be necessary to this process of healing. And that is a recommendation that if we want the people to be resilient, we have to create spaces where they are able to speak about their trauma, but also to build that trust and tolerance to facilitate this process of being resilient. Thank you for your attention.
Thank you so much for the interesting presentation. So I'll take a few questions if you have any, or if you would like to have any clarifications from her. If there are no questions, then, yes. Or maybe try to speak maybe you're loud.
Thank you very much. I think my question will go together with the previous presentation from Mr. Joseph. And I think very recently we have heard some of the reports from the RBC about the mental health issues. I think this report is probably from RBC. And for Joseph, I would like to know how does he associate this with maybe a long-term trauma. Maybe it has been a trauma for a long time that Rwandans have been facing, and maybe those historical events that we are having. And again, I would like to know from your side, I think you are in the mental health, you are a mental health practitioner, and you are a specialist in this. What do you think this community-based health decentralization, mental health decentralization will help? Do you think if we can have, like, as we are having abajyanama b'ubuzima, is it possible if we can have this training for this abajyanama b'ubuzima just to be able to treat or to help those people with mental health issues? Thank you.
Thank you for your interesting question. I think in this community approach, we have done a lot training people in the community level. But now what RBC is trying to do in a mental health division is also to add a package of trauma treatment and the intervention in crisis for those bajyanama b'ubuzima. And I think that will help a lot in the community because
the situation of how it has been with mental health, it's going to go, that's why I was saying the fourth wave or the fifth wave. There is going to be a wave on mental health, and we are seeing it happening. Does it answer? Thank you very much.
Good. If there are no further questions, let's give a big clap for all of you who presented this. And then, yes, to take you through the program for tomorrow. So tomorrow we are resuming at 8:30 here by registration. And we start by opening ceremony by 9 sharp. And then after the opening ceremony with different guests that we are expecting tomorrow. So we are having also different sessions, like we had different sessions today. So all those sessions also are related to forensic science. But this year we also we are bringing another session, which is a special session for COVID. You have seen in the program. And I think everyone is being concerned by COVID. It's better just to know how we can just cope with COVID and also address the issue of the forensic science. Again, thank you very much for your participation. It was a pleasure just to have you very active today, even if it was a very intensive day. But we hope tomorrow we get you again with this high energy for this session. Again, thank you very much, and see you tomorrow.